Yes, last night, and we were able to break some bread and speak last night. But welcome again to Xavier for everyone. And I say welcome to Xavier because you are here in a very special place. A special place that was handed to us. I'm saying handed to us because we did not make it, and we carried forward. And we were handed to us for one purpose, to be of service. When I tell our students, some institutions have missions that are changed periodically. Our mission has stayed the same since our beginning, and the words may be nuanced, to contribute to the realization of the more just and humane society. And our students, when they graduate from here, there's one thing that they do know. You may be a chemist, you may have studied history, you may have studied art, you may have studied neuroscience, but none of that means anything until you graduate from here and go put it to the service of someone else. So service is in our blood, it's in the thinking of our students. And I will give you one short story from we have a group from my own students who taught me as a new president. We have a group called the peer deans, who are upper class students who help the new students move in on moving day, which is a chaotic day at Xavier, but a lovely day, usually sunny. And when I stepped out among the peer deans and asked one of the students in the group, why are you doing this? And one young man stepped out and said, so that they'll know next year's their turn. So now it's my turn, it's your turn, and we're here to think about some things that are very important, because health, and I elevate it to the notion of community well-being, is fundamental to building the society, to becoming what we hope to be, the unfinished American project. So I welcome you, congratulate you, and I thank you for this work. And I'll be listening. Thank you. Now, if I may introduce Congresswoman Robin Kelly. I'll give you the podium. Welcome.
Good morning, everyone. Thank you for joining us for this exciting summit to talk about health equity. I want to start by thanking National Minority Equality Forum for hosting this event, and Xavier University for allowing us to host our event here today. And thank you for the food was wonderful. And I always walk away from this event with a better understanding of the health equity issues we are facing nationwide. This year, I had the honor of leading the introduction of the Health Equity and Accountability Act as chair of the Congressional Black Caucus Health Braintrust. The Health Equity and Accountability Act is a tri-caucus. That's the Congressional Black Caucus, Congressional Hispanic Caucus, and Congressional Asian and Pacific American Caucus. It's a collaborative effort that has been introduced every Congress since 2007. My late esteemed colleague, Congressman Elijah Cummings, was the original sponsor of the bill, and we carry on in our quest to eliminate health disparities in his memory and his honor. He was a great man. The Affordable Care Act, along with other key pieces of healthcare legislation, include HEAA provisions. It continues to be the signature bill on health equity in Congress. My team and I have been working on this bill for several months, consulting with my colleagues, with legislative and committee staff, and with community stakeholders like the National Minority Equality Forum and the National Urban League. We want to be as thorough and as collaborative as possible because health equity impacts everyone. When members of our communities do not have access to health care, suffer disproportionately from certain conditions, or are not included in our healthcare solutions, we all lose out. The COVID-19 pandemic has exacerbated existing health inequities, but also brought further attention to the issue. It's costly for our economies, and it contributes to a cycle of poverty and diminished earning potential for folks without access to appropriate care. Beyond the economic impacts, addressing health inequities is just the plain right thing to do. Dr. King famously said that injustice in health is the most inhumane form of inequality. It is in that spirit that we seek to address these issues and bring quality, affordable healthcare access to all Americans. Today's summit is an opportunity for us to continue that collaboration and to take a deeper dive on several sections of this bill. Our 2022 summit is premised on the understanding that persistent health inequities in this country are unacceptable, but also correctable. We will start today by addressing the history and legacy of the Health Equity and Accountability Act. In understanding the bill's history, we can better identify ways in which health inequities have been addressed, what has worked and what has not. In other words, the good, the bad, and the ugly. We will then move into a panel about mental health equity. Just this week, we heard President Biden speak at the State of the Union about the importance of addressing our nation's mental health crisis. I was so pleased to hear that his administration will be taking additional action on this issue, including increasing and diversifying the mental health workforce. Our third panel will address the healthcare workforce more broadly and hopefully identify some solutions for building a more diverse healthcare workforce pipeline. Finally, I will be joined by Congressman Troy Carter from right here in New Orleans and Congressman Jim Costa from California to talk about legislation to advance health equity in the 117th Congress. Both congressmen have some interesting ideas about how to address these issues, and I look forward to speaking with them. I'd like to thank all of our panelists today who are here with us or joining remotely for our summit. Hopefully, we will all leave inspired and refreshed in our dedication to solving health inequities. Thank you so much. And with that, I'd like to introduce Dr. Gary Puckrein, the backbone of this event. Thank you.
Thank you so much, Congressman Kelly. I also want to thank Dr. Verret and the team at Xavier for hosting this event. And I also want to thank Anita Burgos, who works with Congressman Kelly and has been partnering with Brandon Garrett on my staff to make this event possible. I love events like this. One of the things I learned in my journey in healthcare, because I didn't start out in healthcare. My doctor is actually in history. I got the healthcare through the Holiday Inn. But one of the things I learned is that health policy is medicine. If you are not advocating, you're not doing healthcare. When people walk into the physician's office, they don't realize that a whole community in legislation and policy is defining that experience that they're having with their physician. And so a meeting like this is so incredibly important because lots of Americans are not going to know what we did here, but their very lives are going to be changed by what we actually do. And one of the things that we've been thinking about at the National Minority Quality Forum is that the healthcare system that we currently are under, we call it the legacy healthcare system, was born during an era of segregation and inequality. Segregated hospitals, segregated medical societies, a general recognition of the inequities in terms of what was happening to minority populations, but really no interest in changing them. And so when we look at that legacy system, we don't think it's reformable, right? It's doing what it's built to do. It's built to do inequalities. And so a meeting like this for us is a moment of reimagination. What is it that we want our healthcare system to actually do? How do we want it to perform? And our understanding of healthcare is that it is about lowering patient risk. It's about lowering your risk for a hospitalization. It's about lowering your risk for an ER visit. It's about lowering your risk for disability. It's about lowering your risk for mortality. That is its only job. It doesn't do anything. It shouldn't do anything other than that. But we have confused the purpose, right? Sometimes we think it's about money. And sometimes we think we need to subordinate lives to money. So our argument is that we need to reimagine this system so that it's focused on its principle, because guess what? Every American who goes into the healthcare system expects the system is going to lower their risk. Not one of them goes in with the expectation that the system is going to elevate their risk, and it is elevating risk, right? When we talk about health disparities, we're talking about elevating risk, period. That's what it's doing. And so a meeting like this is so incredibly important to us, because here's where we get to share ideas and think about the future. And along the way today, I'll tell you some of the things that we're thinking about at the National Minority Equality Forum, because at the end of the day, at least from NMQF's perspective, what we want to try to do is be a catalytic agent. We can't do this on our own, but we can partner and have conversations. So I want to thank you for taking your time. And you know, I was telling everybody, this is my first travel in 2 years. I was hiding under the desk from COVID, and I decided, well, I'd better come out. And I appreciate you coming out and taking the risk, because I think we have some incredibly important work to do. And then finally, before I get on, I just want to thank Anita Williams. You see that gold jacket that he's wearing, man? I like one of them gold jackets myself. Hall of Famer, but he took all of his talent and his celebrity, if you will, and brought it to community. He worked on getting people vaccine here in Louisiana, has worked with children, with program with Centene. In fact, I was in St. Louis in a program that Centene put on in St. Louis, and in the middle of the program, this was a children, junior high school students, auditorium full of kids. And the question was asked, these are all minority kids, how many of you have been affected by gun violence? Everybody stood up. It was like, whoa, everybody stood up. That says so much to me about where we are and where we need to go. So I want to thank Anita for all that you're doing and giving back, just tremendous. So let me stop here. We've got a program to get on, and looking forward to our conversation. Thank you.
Here we go. So you guys can take a seat, get settled, and we're going to get started with panel 1. And again, thank you all so much for being patient as we try to set up this hybrid panel. So for those of you who don't know me, I'm Congresswoman Robin Kelly's Senior Health Policy Advisor. I want to tell you a little bit about myself before we get started. I'm a neuroscientist by training with a PhD in neuroscience from Columbia. And in my time in DC, I've really focused on advancing equitable mental health and increasing access to drugs and treatments for everyone. And so I'm really excited about being able to kick off this HEAA programming with panel 1, because this panel will really set the stage for the rest of the programming today. During this panel, we're going to talk about the history and the legacy of HEAA. The Health Equity and Accountability Act, as the Congresswoman mentioned a little bit earlier, is a tri-caucus collaborative effort that has been introduced every single year, every single Congress since 2003, and was initially introduced by the great Representative Elijah Cummings. And I want to take a moment to really emphasize the focus of HEAA. And the focus of HEAA is to advance racial and ethnic health equity. We look at it through an intersectional lens, but this is a tri-caucus bill, and it is a bill that really focuses on communities of color first, and in all of the other ways that, all the other intersectional identities that contribute to their access to care and their health outcomes. HEAA is over 1,600 pages, so it is quite an undertaking for a staffer to lead this bill, and there are 10 titles. that address a wide-ranging number of topics, including maternal mortality, which is something the Congresswoman cares deeply about, expanding mental health and substance use disorder services for communities of color, increasing funding for services for communities of color living with various diseases, including HIV and AIDS, improving quality of care, improving data collection, culturally competent care, and addressing the social determinants of health. As I mentioned, every year a different member of the Tri-Caucus introduces this bill, and this year, Congresswoman Robin Kelly is introducing the bill in her capacity as CBC Health Braintrust. This Congress, I've worked really closely with our external partners, the National Minority Quality Forum and the National Urban League, to gather stakeholder input and Tri-Caucus input into this bill. And so far, we've received input for titles 1 through 10, so we're almost all the way there. We are planning to introduce HEAA the last week of April to coincide with National Minority Health Month. So with that, let's jump right in and introduce this all-star panel. And so one quick check, will the panelists be located on the screen? To my right? There we go. Awesome. So as I introduce people, please raise your hand and do a quick wave so we all know who you are. So I'm going to start off with Dr. Lydia Isaac. Dr. Isaac is the Vice President for Health Equity and Policy at the National Urban League. Dr. Isaac has a faculty position at the Johns Hopkins Bloomberg School of Public Health in the Department of Health Policy and Management. She mostly served as the executive director, or most recently served as the executive director at the Robert Wood Johnson Foundation. Previously, she's also been the director of policy and health systems analysis in the Office of Policy, Planning, and Strategic Data in the First Deputy Commissioner's Office in the New York City Department of Health and Mental Hygiene. She has a bachelor's in ecology and evolutionary biology from Princeton University, a Master of Science in Health and Social Behavior, and from Harvard School of Public Health, and a doctorate in health policy and management from the Johns Hopkins Bloomberg School of Public Health. Next, I want to introduce Erica Ninoyu, who transitioned from a 10-year career of teaching public schools, advising the superintendent on DEI issues, and serving as a community leader and transitioned from that into federal policymaking, so quite a large jump. Erica serves as Congresswoman Barbara Lee's legislative assistant, focused on health, equity, environment, and interior, and energy and water, agriculture, and poverty. That's quite a portfolio. Previously serving another member of the House Appropriations Committee, Congresswoman Grace Meng, as her Asian Pacific American Institute for Congressional Studies Congressional Fellow. During that time in Congresswoman Meng's office, she worked to expand her education and civil rights portfolio, and that work led to the passage of the House Resolution 908 condemning anti-Asian sentiment due to COVID-19. Erica has a master's in education policy and management from Harvard University. We have a very esteemed panel today. And I'm saying this because we're in New Orleans and this is relevant. Erica's a musician at heart. So she still performs with the Mark H. Rooney Tycho Connection throughout the DMV area. So maybe we'll hear a little bit about that too. And most importantly, Congresswoman Lee is going to be leading the bill next Congress, which is really exciting. And so we're really thankful to have you here today. And next I want to turn to one of our virtual panelists, Gloria Nunez. And Gloria, do a quick wave, Gloria. Hi, Gloria. Okay, so Gloria Nunez currently serves as the legislative aide for Senator Cory A. Booker. She works on health, education, and appropriation issues in the office. Gloria holds a master's in government from Johns Hopkins University. Really excited to have you here as well. Very thankful for the Senate perspective. Next, I want to turn to Dr. Gary Puckrein, so if you give us a quick wave. Dr. Puckrein is, as you all just heard, the founding president and CEO of the National Minority Quality Forum, a nonprofit healthcare research, education, and advocacy organization headquartered in Washington, D.C. The mission of NMQF, as Dr. Puckrein mentioned in his opening remarks, is to reduce patient risk by assuring optimal care for all. NMQF conducts evidence-based, data-driven initiatives to eliminate premature death and preventable illness. NMQF's mission is an American health services, research, delivery, and financing system whose operating principle is to reduce patient risk for amenable morbidity and mortality while improving quality of life. Dr. Puckrein received his doctorate from Brown University. And last but certainly not least, we have Dr. Britt Weinstock. So Dr. Weinstock has worked in the fields of, Britt, give us a quick wave, of health equity, health policy, public health planning, assessment and evaluation, and health care financing for 25 years. Dr. Weinstock currently serves as the principal and chief strategist of the Health Equity Strategies Group and represents clients who focus on advancing health equity and eliminating health disparities. Dr. Weinstock holds a Doctor of Philosophy in Sociology with a co-specialization in Medical Sociology and Social Inequality, and a minor in Bioethics from Howard University, a Master's of Arts degree with a concentration in Social and Public Policy from Georgetown University, and a Bachelor's of Arts degree from Bucknell University. And I think most relevant to our panel, Dr. Weinstock has done a great deal of work on HEAA and it really led the charge early on with this bill, and really excited and very happy to have her on the panel. And thank you to the virtual panelists for all of your patience as we try to kind of put together this hybrid panel. This is definitely a first for me. So with that, I'll just take a seat and we can get started with the panel. So, Dr. Isaac, let's begin by discussing the need for legislation that advances health equity. Before we even get into HEAA, why does health equity matter? Can you speak a little bit about the need to address health equity and what contributes to health inequities in our country?
Yes. Good morning, everybody. I'm so happy to be here representing the National Urban League and seeing all of your beautiful faces, though these lights are kind of bright, and I can't really see your faces, but I know you're there. I think this is really important. I think in the beginning, in our opening, we talked about the health inequities that are happening in our country, and the reason why HEAA is so important is because a lot of times we want to focus just on the healthcare system, as Gary said, that, you know, the system is supposed to be there to help people reduce disease and reduce risk. But when we focus just on the healthcare system, we don't think about the larger aspects or the other, what we call social determinants. And I will say, as a title lead for the social determinants section, that's going to be my focus. We don't think about and really focus enough on the 70 to 80% of factors that really impact people's health outcomes, which is where they live, where they go to school, the policies like Gary talked about that impact not only healthcare, but education, but economics, where people have jobs, how they're able to live. And so it's really important for us to think about health equity in a broader aspect than beyond healthcare, which is really important. So access, we know for a fact that the ACA, and we have to give really kudos to the Obama administration for getting the ACA signed, helped with the access issue, but it didn't solve the access issue. We still have huge access issues in this country for communities that we care about, for low income, for rural populations in particular. And so that's still something we have to focus on, but we also need to think about the health promoting environments that surround people. You know, we know the Flint water crisis, we know the Superfund sites, we know what is happening around where people live and how that's impacting their health, which are causing larger disparities and more inequities. And those inequities are baked into our system and how we educate, how we provide jobs, where people are, you know, how we zone, you know, big things now with how we zone areas for what people have access to and services. And so HEAA is really important because what HEAA is talking about is all these other aspects, including access to care, and trying to get us to codify in legislation and policy the other social determinants that are impacting the way people live. And so just to start that broad base, that is why, you know, a lot of people will say, well, why? We have legislation on healthcare, we have legislation on this, but for having people to understand the intersector issues that involved and the social determinants and how those combine and work together to create poor health is what HEAA is addressing. And so it's seeing the whole picture instead of looking at it at the discrete pieces.
Absolutely, I think that's a great way to start, and especially given, as I said, Titles 1 through 10, they really do try to address health equity in a very holistic manner. So I think that's a great way to start the conversation. And so next I wanna turn it over to Dr. Weinstock. So HEAA was first introduced in 2003, as I mentioned earlier, by Congressman Elijah Cummings. And could you provide a historical perspective on how that bill initially came together, just for the audience here today?
Maybe, okay, there we go. You can hear me?
Yes, we hear you and we see you.
Okay, hi. So first of all, good morning. I will own it. I'm the reason why we started a little bit late this morning because I'm calling in from Florida because it's my mother's 80th birthday. So I'm sorry I'm with you because I love New
Happy
Orleans.
birthday to you.
and I love gumbo even more. So anybody coming back to DC with some gumbo, I will take it. So just to get back on track. So, this is such a great question and such an important piece of legislation. This started, the topic of health disparities has been around, from as far back as the Philadelphia Negro. And then it came through and people were talking about these black-white differences predominantly. You had it in the SAP report in the 80s. People were talking about it around the edges. But then in 2003, the then Institute of Medicine released the landmark unequal treatment report. And that got national attention because unlike other studies, which were very valid and very important, unequal treatment focused on disparities among the equally insured. So it made it difficult for people to say things like, oh, well, there's this disparity because you're on Medicaid or you're uninsured or underinsured. It really controlled, the studies that were looked at controlled for everything but race and ethnic background. And what it found was that even when Black and brown people were equally insured, had similar socioeconomic statuses, had similar incomes, even in some cases lived in similar areas, the disparities were still profound. And there was a series of recommendations that came at the end of that report. And I have to give a big shout out to Dr. Brian Smedley, who hopefully he's not in Louisiana. He's certainly calling in because he was one of the chief editors of that report. Those recommendations were then taken to heart. And it was the late, great Congressman Cummings, who at the time was the chair of the Congressional Black Caucus, who got together with his colleagues across the Hispanic Caucus and the Asian Pacific American Caucus and said, it is time to do something because we now have evidence, and a lot of it, that says that Black and brown people in this country, not only do we deserve more, we've earned more. And that was what sort of the catalyst to the first disparities bill was. Now, back in 2003, and I've had a lot of folks sort of text me and email me, it had a different title. It was HR 3459, and it was called the Healthcare Equality and Accountability Act. It was introduced in 2003 with 125 co-sponsors. Since then, every year, it's been introduced as the Tri-Caucus landmark piece of legislation because what it offers is really a comprehensive roadmap to really not just address the disparities numbers that we see every year, time and time again, but to really get to the root of the root causes of equity. And the good doctor from the Urban League talked about the intersectional approach. Well, what this bill has done over time, it now embraces also, it looks at everything through an equity lens. And that means that it's not just intersectional, we're also pulling in other groups that are disproportionately affected by all these forces that lead to disparate care and disparate health outcomes. So in 2007, the name of the bill was changed, and that's when it was still the same legislation, just a name change, and that's when it became the Health Equity and Accountability Act. In 2007 is when we started pulling in, and Tri-Caucus started pulling in so many other groups that have been neglected. And again, looking at the intersectionality, there were Black and brown people across those groups as well. And so there was a cognizance that there's power in number. And since then, this bill's been introduced each and every congressional session. So I know that's sort of a lot. Dr. Burgos said the bill is a dissertation, but this problem wasn't as big as it was and wasn't as longstanding as it is. We would be able to put together a bill that was shorter and smaller. But this bill is very comprehensive. It really cuts across everything, and it speaks to something that my colleague at the Urban League said, that it talks about more than just your access to healthcare or your access to a doctor. It really takes into consideration things that we now know from data collection and reporting, that your zip code often is more important than your genetic code. We now know about implicit bias across the healthcare system. We know about the successes that were achieved in ACA, and we also know the work that remains to be done. And then unfortunately, because of COVID, anybody who doubted all of these social determinants, and I would actually argue also political determinants of health, now knows that it's very hard to not see that this healthcare system treats people of color, Black and brown people, and people that you can put into what they call a disparity population differently than others. And that needs to change, and the time is now.
Yeah, absolutely. And I think you kind of got into a little bit into the second part of the question that I wanted to get into. So as I alluded to earlier, when I introduced you, Dr. Weinstock, you were the health staffer for former CBC Health Braintrust Chair, Congresswoman Donna Christensen. And so you started to talk a little bit, but could you focus in a little on how HEAA evolved during your tenure? Kind of what were the topics that folks were talking about at the beginning, and how did that change over time?
Sure. Yeah. So in 2003, the primary focus was always around racial and ethnic minority Americans. But as we started to collect more data, and more importantly, as that data started to get collected, as a result of Mr. Cummings and the other Tri-Caucus members' efforts, more researchers who were in this space started getting funded. That was an important piece. We started to see that this cuts across so many other communities. And with the Tri-Caucus, it's always been sort of the mentality has been, we're going to advocate about, on behalf of anybody and everybody who you could put into the category of the nameless and the faceless and the voiceless. And those happen to be the same individuals who are affected horribly by health disparities and health inequities. So we really I would just say, we realized that the health equity table was a pretty big one when we started. Once we had more data and more reporting, and then more stories, and quite frankly, just more proof and more leverage, because we have to remember this is all happening in a social and political sort of in the backdrop. We just made the table bigger. So we started putting more focus on LGBTQI populations. We'd always put a lot of focus on people with disabilities, people with differing abilities, but then we started pulling in and looking at the differences with people who are in rural communities. We started pulling in and realizing that we've got almost 4 million Americans who live in the US territories that no one was talking about or remembering. So we started pulling in, those communities. We started pulling in, looking at gender disparities. We started looking at developmental disparities, obviously SES disparities. So to answer your question shortly, we just started pulling in as many people as we could who, you have different faces and different, preferences, et cetera. But we were just pulling in people who could unite around a common goal. And that goal was to achieve health equity. So over the years, the table has gotten bigger. We've just built more chairs, and so at this point now, I think that we've got a really great opportunity, because we've got a really robust community of folks who are interested, a robust community of folks who know this has been a problem, folks who were looking at this back when I was still in diapers, quite frankly, and I'm 49, I'll say it. But we have folks who are new to the fold, who bring a lot of energy and, quite frankly, great ideas and perspectives. So it's really nice to see how this movement has grown and evolved and expanded. And so I think that's one of the greatest successes about this bill, even though the whole thing has not been signed into law. We have this community of health equity warriors who don't shut up easy, and they don't take no easy either, So we're very lucky in that respect.
Definitely. Yeah. Thank you so much for offering that perspective. And we're going to get into, over the course of the panel, we'll get into a little bit some of the successes that he has had, the pieces that have actually been passed into law. And so we were talking about some of the strengths of HEAA, and I love how you kind of brought in that there are now more folks involved and more folks really pushing for the passage of this bill. Another really important strength of HEAA is that it is a Tri-Caucus collaboration, and and that's been part of its history. And so, Erica, if you could speak a little bit about the history of Tri-Caucus collaboration with this bill.
Yeah, thanks so much, Anita, and for all your work on this bill.
You'll see soon. Yeah.
It's an honor to be here representing Congresswoman Barbara Lee. She has the advantage of being both on the CBC Health Task Force and the co-chair of the KPAC Health Task Force, and so we'll have the honor of carrying this in the next Congress. I think what we see as a true strength is that we get to collaborate among the Tri-Caucuses. HEAA is the bill that functions as our North Star, the blueprint of what we want to change and what should be already enacted in terms of health equity. And so this is a way to bring CHC, CBC, KPAC together each year, or not, each Congress, a different member of Congress leads the bill. And so in the 116th Congress, it was CHC, CBC this year, KPAC next year, and the rotation will continue. And in addition, each leg of the Tri-Caucus works with its key stakeholders. Each Congress, there will be a different lead, but the other strength is there's a sense of continuity throughout the decades of the work on HEAA. And so we've had, 300 stakeholders work on this. And because of the depth and breadth of the bill, you have easily 150 members of Congress who are on board advocating for the bill. So in terms of creating a movement and really talking about and energizing the need to uplift health equity and furthermore enacting change in policy, we have a huge team to work with here. And we have the living experience, right, of all the inequities. I'm second generation Japanese American, seeing my parents, hesitant to go to a doctor's visit, right? I think a lot of us have been there. So it's so important that we are the ones creating these policies. And unfortunately, that wasn't always the case. So, really having those experiences within this bill is, I think, a true testament to, what we will achieve. I'm very optimistic that this is doable. So it's just wonderful to be a part of this process.
Yeah, thank you so much, Erica. And do you have any thoughts kind of as you start thinking about next year of things that the Congresswoman would like to prioritize during her leadership of the bill?
Yeah, that's a difficult question because all of these titles are so important. But I can tell you, we have been working on whether it's health workforce. That's a lot of times not elevated enough because the outcome is kind of takes some time to see the results of that. But working, with the Tri-Caucus members and stakeholders to continually point to HEAA when they're talking about their individual health equity bills, so they know that, and the public knows that this is part of a grand movement. And this is, we've seen through COVID what's possible when the world pays attention to the needs of the underserved communities and communities of color. We see it wasn't fast enough, but we know that the government can mobilize, and we know that those results help all Americans. So lifting that up and building off of that, I think next year it's going to be about taking all of this work and continually pushing it forward with the help of all Tri-Caucuses.
Yeah, absolutely. And I think another huge strength of this bill is that it's a bicameral effort. So it's both Tri-Caucus and also a collaboration between the Senate and the House. And so we're really happy to have Gloria on today. So Gloria, how is the Senate working to advance HEAA this Congress? And what are other health equity priorities that Senator Booker and other members in the Senate have been pushing for?
Hi, good morning. I'm very happy to be here. I'm going to start off by saying that we're very thankful to be working with Rep. Kelly's office on this. Due to Anita's coordination, we have been able to effectively communicate to Senate offices, and many Senate offices are already aware that this bill is coming. We have been getting a lot of positive feedback, and a lot of offices are excited to see the final language and help elevate this legislation. One of the silver linings of the COVID pandemic is that people, especially senators, are now paying attention to health disparities. We have known that they've been there and it's been a part of our system, but we have seen a change in the Senate, whereas more senators are looking to work even bipartisanly to introduce legislation that address these issues that have been prevalent, and we know they've been prevalent, but they have not gotten the attention that they should. Some of the other efforts that we have seen, we're very proud to have inherited from Vice President Harris, the Black Maternal Momnibus. That is legislation that was actually included in the Build Back Better, and we are very hopeful that will be included in future versions of Build Back Better that will be signed into law. We are fortunate that the administration has actually paid attention to this. It is a priority for them, as it is a priority for Rep. Adams, Rep. Underwood, the CBC, and Senator Booker. And we're seeing even bipartisan pieces of bans. There's a veterans, it's a 2/3 of the Senate's actually co-sponsoring, which is unprecedented. And there's been portions, including a veterans legislation that actually was signed into law last year. Other pieces that deal with equity that are not in HEAA, but hold the same sentiments are sickle cell disease. It is a disease that has been neglected because it is predominantly African descent disease. There was no funding, no research, no treatment. In 2018, Senator Booker and Senator Scott signed into law data collection and treatment legislation. Now we have a CBC program that collects data every year on sickle cell disease, and we have a HEAA model. December last year, we again introduced with Senator Scott bipartisan legislation that would create a CMS model to create more treatments and do more research in sickle cell. So the willingness is there, and we have seen that it is possible to pass some of these pieces of legislation in a bipartisan manner, and we're very optimistic seeing the positive feedback that we have already received from a lot of Senate offices.
Yeah, I think that's great. And you hit on some really good points. And as you all know, maternal health is something really important to Congresswoman Kelly as well. And she's been championing her Mama's Act for a long time in Congress. And so that's definitely a place where we're paying a close attention to in HEAA. And I think the second point you made, it was about the bipartisanship, how now maybe issues that weren't as bipartisan before, now there is an increased awareness about health disparities and a willingness to kind of work together. And we've seen that also in the clinical trials diversity space, where the Congresswoman's been working on a bipartisan manner on legislation to increase diversity in clinical trials. So really appreciate those 2 points. And so we can start, we've kind of been talking a little bit kind of broadly about the bill and how it first came together, some of the strengths of the bill, but now let's start talking about the bill itself, right? So Dr. Puckrein, you are an expert on many things health equity, but specifically you really care about data-driven policymaking. And so what role does data play in closing the health equity gap? Or what role can it play, rather, in closing the health equity gap? And how does HEAA address some of the gaps in our data?
Thank you so much, Anita. Let me frame your question a little bit. One of the things that's happening that's incredibly important in our society is the demographic shift. And there's an emerging majority in the country that historically did not get quality health care. And so those inequalities that we see today are really rooted in a time, as I said before, when it was acceptable to have inequities in the healthcare system. And so as we move to make our healthcare system accessible to all Americans, it has to be done by the data. We need to understand, and we don't have good data on minority populations. We all talk about clinical trials all the time, right? And the lack of diversity in our clinical trials. But what we don't say is that diversity in clinical trials means that clinical guidelines are not diverse, right? And so the practice of medicine is being informed by clinical guidelines that are not diverse. And guess what? CMS takes those clinical guidelines and turns them into performance measures, right? And so you have performance measures which are not diverse. And so the whole structure of the system, the way it's built, builds inequalities. And so what we have to do is we got to go back from the beginning and start. So at National Minority Quality Forum, for example, we've launched the Alliance for Representative Clinical Trials, because what we want to do is we want to get clinical trials in our community, right? They have to be in our community with community clinicians who are treating folks in our community, who understand the community and can help bring that diversity in clinical trials. We also want to make sure that we're taking that data and we're going back into practices and helping them to understand, why are we getting these poor outcomes? How can we use the data to better inform what we want to do? And then most importantly, we want to use the data for advocacy, right? Healthcare policy has to be data driven. And one of the things I find most unusual about healthcare policy, that it never tells you patient outcomes. People write these legislations and they never tell you what's actually going to happen to the patient. They tell you what's going to happen to the money, but they don't tell you what's going to happen to the patient. And that's the point, right? The healthcare system has to be about the patient. Our patients are diverse, so we have to understand that diversity and to make sure that every patient who comes into the healthcare system gets the quality care that they're anticipating, that they're actually paying their money for, right? Because guess what? All that money comes from the American public. And so that's why I'm so excited about HEAA, because now we're starting to reimagine the healthcare system for our future, right? Because by the time we get to 2040, America is going to be completely diverse. California is already diverse. Texas is already diverse. Georgia's already diverse. It's here, right? And so it's incredibly important that we take legislation like this. And I would say to our industry partners, that's your market. Your market is emerging, right? And you have to pay attention to it. And so that's why I think this conversation here is so incredibly important, because we're laying the foundation for that future.
I just want to make a point to follow up on that. I think what we've just been talking about, and Britt made a really good point about bringing everybody to the table, and Gary just talked about this demographic shift. The HEAA is not just about disparities populations. HEAA is about Americans, right? And I think we need to be very clear and really try to hone into the point that what happens here, how this bill helps these populations actually helps the health of Americans in general, because one, so many people are in the table, as Britt said, but also as this demographic shift happens, these are the populations that are going to drive life expectancy, that's going to drive the health of the American population. And so I think it's really important for us to message that this is about keeping Americans healthy. People who live in this country, whatever their status is, it's about keeping the residents of the United States healthy. And these policies are really going to drive home and create environments and systems that keep Americans healthy. And I think that's important for us, because sometimes we get into, well, why should my tax dollars go for this? That's not my population, or that doesn't impact me, but it actually does, because the health of these populations impact the health of our country.
Anita, can I add one thing? Can I just add one thing all the way? I'm sorry to interrupt you. I just want to.
This is a conversation. I want this to be as interactive as possible.
Right. Okay. I just want to clarify one thing. One of the things that the Tri-Caucus was so proud of early on, and this is going to put the good doctor from the Urban League on spot, was that we weren't looking at this as a bill for Americans. We were looking at it as a bill for human beings, period. We pushed back hard, and we always have on things like the sit-doc regs. I remember Donna Christensen, when she was in Congress, she was the only African-American MD, and she's traveled all over the world. And she said one of the things that always struck her is that here we call these nations developing nations, yet they didn't care where you were from. If you needed care, if you were medical duress, you got it. Here we are, one of the most developed countries in the world, and we're busy looking at people's passports. And so that's just one point I wanted to make, that the original spirit of HEAA didn't look at Americans. We didn't even care where you're from. We looked at people as human beings, and just had a huge emphasis on people of color. But we didn't, and we shouldn't care about citizenship, because if you're here, you're living here, you need help, or even if you're staying here and you need help, you should get it, because we can afford to give it to you. That's one point. The second point I just want to hit on real fast is something that Dr. Puckrein said, because I think he's being really humble. And Anita, you said it best. He can talk all things health disparities, and he talked about the importance of data collection and data reporting. And I do think that he's been doing this for a long, long time. And I think that the idea of looking much further upstream about not just how data is collected, but what type of data is collected, is it disaggregated, and then more importantly, is it being reported? Because when you look further upstream, to Dr. Puckrein's point, there are policies that people build around that, but then there are things put into place that then have a disproportionately horrendous impact on the very populations that weren't a part of that data collection kind of algorithm and methodology in the first place. So, and I always say, I would say it all the time. I always say, no data, no problem. And then when you look at other things, and then no problem, no funding. So the data collection reporting piece of Dr. Puckrein, I've looked at him and his work for the last 2 decades. It's unparalleled. It changes the course of a conversation overnight. When you have the data that you need, and when it's disaggregated, and when the analysis is there, because you really do stop people in their tracks. And I'm not saying that the folks who are doing a lot of these coverage decisions are ill-intentioned. I will give them the benefit of the doubt and say that some of it is implicit bias. But when you arm them with the information, you take away their excuse to say, well, we just didn't know. So I just wanted to sort of add that to the conversation. Sorry to interrupt.
No, I think that's good, and I want to encourage people to interrupt, so Erica,
Yeah.
jump right in.
And that was, the point that I was gonna make is we need to take, as we reimagine the healthcare system, we need to take a better look though, and that comes with what the data disaggregation piece. For KPAC, a lot of times the data that is collected is Asian, Pacific Islander, Native Hawaiian. Before that, it was just Asian and other, right? But the culture, the needs, the unique needs of each community are vastly different even within the Asian American community. And so, in the future, hopefully, when we talk about disaggregated data, we can dig deeper, look a little closer of what America looks like.
Yeah, and Brett, you didn't put me on the spot. I agree with you. When I think Americans, I think everybody who's in this country. So that's why I said residents. It doesn't matter who they were. I wasn't separating undocumented folks or any other folks. But I agree with you. But my point is that I do think there is, the point I was trying to make, I do think there's a section of people who would say, why should this be important to me? And the point is that it's important because it's about everybody who's in this country, period, like, or in the world, but this is impacting policy in the United States. And so I think it is important for us to say this impacts everybody, and it's not just, oh, well, I don't have to worry about that because that's not a group that I belong to. And so thank you for you just putting that out. And it's nice to hear the history, but my point was everybody who's here, it matters.
Yeah, and I think that's right, especially because there are areas of the country that are not as diverse yet, right? And they have representatives and they have senators, and so we have to get them on board.
Right.
And so that is one way to kind of bring everyone along. And a lot of the changes that are proposed in here are to improve the health system overall. So I think that is something that would benefit everyone. And I like that we kind of started with data collection, because that's the title, that's the first title of HEAA, right? So that's like really setting the stage. First of all, we need to, kind of as Britt was saying, we need to understand the problem, we need to collect data on the problem. No data, no problem. So I liked that. So I think, we're starting to get into the meat of HEAA a little bit, which I think is great. Are there specific policies in HEAA, the bill is large, but are there specific policies that that you are most excited about advancing, and maybe, especially if there are ones that maybe don't get a lot of attention? I think that would be something great to kind of inform our audience here today and our audience virtually. So if someone wants to start off with that one.
Let me take a moment on the data issue before we move on. So it's not just about collecting data, right? If you actually think about it, data is actually pretty stupid because it doesn't tell you anything. It's the analytics of the data that's incredibly important. And the challenge, one of the biggest archives of data that we have right now is the federal government. Very difficult to get into federal government data, right? I'm just telling you that you have to write a dissertation in order to get access, and it becomes really prohibitive to underserved populations because it requires a whole set of skills that they may or may not have, right? And so we've got to figure out, how do we make the data, particularly in the government archive, a lot more accessible, because you have to fly by the instruments, and if we don't have good data across populations, then we're never going to get to the equity issue. And so we need to stop for a minute and think about how do we want to collect this data, how do we want to make it available, and how do we want to use it to help Americans live better lives. So I think there's a lot of work to do on that data side.
Yeah, absolutely. And I think we could have a whole panel just on data collection, because it seems like something very important and something a lot of you have strong things to say about.
So I'll point out something in here that actually goes with data. So in Title 10, which is the social determinants title, there actually is a part of it to request the Secretary of Health and Human Services to create a planning council to really think about how we coordinate data also across agencies. So as we've been saying about data, is that there is a lot of data in the federal government that says a lot of different things that are collected by different agencies, and they're not paired. They don't connect to each other, and so you can't make inferences or use the data in good ways because this agency controls this data, this agency controls this data, they haven't linked the data. And so, we need better data collection, I agree, but we also need better use of the data we have, and for agencies to share their data, to use the analysis to come up with policies and actions in agencies to help people. And so I think, those little those kind of, I would say, unsexy things you may have in a bill that's about like planning councils and sharing data is actually some of the most important things that really, as we've been saying, impact people's actual lived health experience. And so I would say some of those things are some of the things that we may not, talk as much about, but are really important because they're implementation, they're kind of minutia, but they're the minutia that actually makes the system work.
Yeah, that's right.
Yeah,
And
can I?
go on. Yep.
Yes, yeah, I just want to add to that, and I fully concur, the data piece, and, I do think the data is extremely sexy. I think it's like the new Cardi B, but I'll let that one go. But I do also think that I think that Title IX also has got a lot of, it seems sort of just by title, sort of something that people would say, oh, that's going to put me to sleep. But the accountability and evaluation piece inherently has as a part of its just backbone, data collection, data reporting, how it's collected. That's another important thing. The collection sort of methodology. Sometimes the way that some folks collect data scares people from wanting to participate. I think Dr. Puckrein nailed it on the head too, the analytics side of everything. But the data piece is got to be, and I think there's increasing efforts to make sure it is woven throughout the whole of HEAA. And is woven throughout because, as everyone I think knows, this bill is massive. So often in the past, people will lift one title out or even one section of one title out and put it onto a legislative vehicle that's moving. What we wanted to ensure, and we've done it since 2003, we're doing it now, is to ensure that if you lift out one part of this bill and dump it onto something that's moving, that part alone can stand alone and help kick the health equity ball in the right direction. Data collection, data reporting, disaggregation of data is vitally important to all of that. And so there's been a very concerted effort to make sure that that occurs, because again, without the data, it's impossible to prove a problem. And I will quote the good Dr. Puckrein, who I will never forget this. It was almost 2 decades ago. He sat in a meeting with me, or actually not with me. He was with my boss. I just happened to be lucky enough to be invited to the meeting. And I will never forget him saying, CMS collects so much data. And but these days, it wasn't even CMS, they were called HICFA. HICFA collects so much data, but all that data doesn't give me any curse word good if it sits in a box in the basement. It's sad to know that was almost 2 decades ago, and it's really infuriating that still happens today to a certain extent. It particularly happens in rural communities. It happens a lot in the territories. It happens a lot in areas where it's difficult sometimes to engage folks because they don't have a relationship with the healthcare system. So I think that needs to change. I think there's cognizance of that across HEAA. And just for one other piece real fast, then I'll shut up the data piece. And this is why the evaluation accountability piece is so important, as well as Title 10 and other titles, is that we have populations that are it's extremely difficult to get individuals to trust healthcare systems. So you've got, trans men and women, especially trans men and women of color. You've got young trans kids, you've got young gay children, you've got populations that just are very distrustful because they've been wronged so many times, not just by the healthcare system, but by society. And their stories that we can capture through data of populations, those are vitally important also to any comprehensive health equity movement and effort that really seeks to not make history or allow history to repeat itself. And so that's the other reason why I would say the data piece. But Title IX also is one of these titles, Anita, to your original question, it seems not very sexy, but it really is.
Yeah, well, we can have the debate about whether data is sexy or not sexy, maybe after the panel. But that's all great. Those are excellent points. And I like how you kind of pull different titles in and how they connect to the first title that we were talking about on data collection. But Erica and Gloria, are there any other title policies in here or anything that you are really excited about pushing forward?
Yeah, another sexy one is Title VII. This is the addressing high impact minority diseases. It's really exciting the advancements we've had in HIV. And, as my boss is the founding co-chair of the HIV/AIDS Caucus, we've been tracking this closely. But I think underpinning the entire bill is the fact that a lot of what we're talking about is busting through discrimination, stereotypes, all those aspects. And this time around, even the small changes that we made to this section in terms of changing the wording that we use, substance abuse to substance use disorders, and recognizing that for ourselves so we can better advocate for these pieces too. And the advancements of PrEP, including provisions on that in this bill. So when we go through the bill each Congress, it's really uplifting in some senses because we recognize, yes, so much more work to be done, but also the changes that we've made. And the changes in terminology is reflective of what we've seen in society, whether it's the Black Lives Matter movement, Me Too movement. I think we're ready to put certain provisions in the bill because I think the public is demanding it and we're responding to it.
Absolutely. And Gloria, did you want to add anything? I think you were going to jump in.
Yes, one of the sections that is very uplifting is the improving access, especially for undocumented folks. Like these are folks that are often not talked about and don't really have a voice when it comes to our policy making. And it's not just the right thing to do, it's the smart thing to do. Like we should be providing care, like it benefits all of us. And even if you're looking at it from just like an economic perspective, like it's more expensive to not treat diseases from the upfront. Like we should be providing this care, and it's really important that this is included in there and that we're giving a voice, because those people are these communities are often afraid to like come to a policymaker and they don't really have a seat on the table. So I find it very uplifting that they do get a seat on this legislation.
Yeah. Hey, can I add one fast thing to what you just said, Gloria? Because I meant to add this in. I'm glad you brought that up. One of my favorite quotes came from somebody, and it was she was pushing back on, and I won't say who she was, but she was pushing back on someone who was really pushing back on including undocumented residents. And she said something that I have repeated. I've stolen her words. And she said, unless you're an Indigenous person, we're all undocumented. She said, end of the story, end of the story.
Right.
And I think that gets lost in the shuffle a lot of the times too. So I really appreciate what you said, because I do think that now there is such cognizance that it's not only just the right thing to do, it's something we should do, and it makes the most sense. And quite frankly, it's cruel not to. So I just want to add that in, that I've heard people push back, and when they say it, the person just kind of sits like looking like someone, just sort of, hit them into next week. So.
Yeah, I think that's an important point. And Erica, you had mentioned something that I did want to touch on. You started talking a little bit about the changes in the 117th Congress version of HEAA. And so our staff has been working really hard to take input from stakeholders, take input from staff to update HEAA and include new bills and that sort of thing. And so and you've all been involved in that process. And so how has HEAA changed in the 117th Congress? What are some of the updates that you all have contributed to or are excited about? So Dr. Isaac, if you wanted to start us off.
One of the things that we included is expanding our language around particularly Middle Eastern and North African populations. So added that as a disparity group, changing to LGBTQA+ communities to make sure we are inclusive in that ways. Thinking about, I think Erica made a really good point about the language we use, differently abled instead of disabled. Thinking about what we would say that, used to use the word disabilities for a second, but unseen disabilities, and thinking about how do we, particularly with COVID, and I want to make a point, because I think this is a really important point that I believe Anita has made, is that, COVID has been a moment that's made us see things, but we don't want this to be the COVID bill. We want this to be a bill that can pass beyond COVID and that is going to address things beyond COVID. But what we are seeing with this pandemic, particularly people who have long COVID, is we don't even know how to characterize it, right? Is it a disability? Is it not? And for some people, it's unseen. And we know that there are people 2 years out who are still experiencing symptoms from this condition. So making sure we do add things like that, to add different language, to make sure we're inclusive of things that are yet to come, because who knows, unfortunately, what's yet to come. And we want to make sure that people are covered and that people can get the care and access to the needs that they have. So, doing things like that, or trying to think about how society is changing, how the words we are using, because what we put in these bills are actually really important for the creating the norms for how we talk about people, how we treat people. And I think that's really important. It gets codified in language.
Yeah, absolutely. I think that's a really important
You
point.
know,
Did
I
anyone
want
else
to
want to jump in?
add 2 points to that. One is, I always think preambles are incredibly important, right? Because you want people to understand what you're doing and why you're doing it. And so I would take a deep look at the preamble because that's the intellectual framework around what the bill is standing for. And so I think that's important. I also think we have to understand the context of the clinical issues that we're facing, not to spend a lot of time rolling off numbers that everyone probably knows, but in this country, 60% of everyone with diabetes goes to the hospital or the emergency room every year, 60%. If you're an African American with diabetes and heart disease, you have a 90% hospitalization rate. Who has a 90% hospitalization rate? Again, looking at African Americans, they have the highest level of hypertension in the world, and we're not studying it. There's no study of hypertension in the African American community, which could help lots of other communities if we could understand why their numbers are so crazy. And then just the way in which we treat innovation. We think innovation is some sort of cash problem, and we don't realize that this is how we're going to conserve life. It's the science, and we need to take those innovations and get them out to community, not just here, but in the moment, quickly, right? So you look at CBO scoring, PSDF, preventative service, that's just road blocking, value assessment, I don't even know what the hell that is, right? Because that has nothing to do with healthcare. But that's my point, right? And so in this legislation, we have to understand the context of disease as it is impacting the American public, because that's what we're trying to fix. And so that's why the numbers and the data collection and all that, and that's why the framing of it, the purpose of it gets to be really important, because when people come to that legislation, you want them to understand, here's our purpose, here's why we're doing what we're doing, and all of those tactical pieces that come underneath it, obviously incredibly important, but it is aligned to a purpose.
That's right. Did anyone else want to jump in there? On
Yeah,
some
can
of
I
the
add,
changes? Yeah.
I just
Go
want to
on.
add one thing to what Dr. Puckrein said is around hypertension. And I think that everyone knows this, and I always get both sad and inspired whenever I read this. You know, right now today, as I'm sitting here in Florida, but y'all are in New Orleans having gumbo without me. You know, right now there are 250 cities, counties, and leaders across this country right now that have identified racism as a public health crisis. And you have got independent studies happening across the country that are linking those who experience racism to a lot of these chronic conditions to say that there are a lot of factors that are driving this. Some people call them social determinants, some people call them political determinants, but they are determinants. And so I think that this awakening that this nation is having, finally, some of us have been there. We've been at prom for a while dancing. We're like, welcome, it's a good song, come on in. But I do think that the conversation is shifting, and issues around preamble are so vitally important. But I also think grasping this moment and sort of saying that we're having this enlightenment and changing the way that we're thinking about what leads to these disproportionately high rates of things like hypertension and diabetes and mental health in communities. I think that this is a really great time, and it's in the ground is fertile for us to really take the data, take the drive, take the issues, and really move not just the policy and research, but the discussion and the thinking about these issues in a much different and a much more comprehensive and impactful direction.
Yeah.
Jump on that. So I have a growing list of things, you know, we already can implement in the next Congress when we work on this, but that's a big piece, you know, calling out racism in public health. And Congresswoman Barbara Lee is a co-lead of the Anti-Racism Public Health Act, along with Rep. Ayanna Pressley. And so bringing those pieces, and, you know, I think the strength of the bill is calling out challenging aspects like that too, you know, reproductive rights, and there's language in here that's supporting the exclusion of the Hyde Amendment through hopefully we get the appropriations bill passed for FY22, which that's in, but other things like removal of the ban on using federal funding on syringe services. So, you know, when you take a look at the bill, you also see the political dynamics of what's going on, which is interesting. You know, even if you do a F search of what we put in or take out for the Office of Minority Health, you know, last year we had to put in provisions to protect it, right? So the changes are really reflective of the times, and we can keep on working on that.
Yeah, I think that's a beautiful note, just to kind of highlight that you can kind of track the conversation of health equity by tracking what's in here and what's not in here. So I think that's a really important point. One thing I wanted to also point out is that there's more, there's a big effort now with this bill to include more awareness about the clinical trial diversity issue. So I kind of touched on that earlier. So there are a couple of bills, including the Congresswoman's bill on clinical trial diversity, that will be included in Title VII. And also we had a mental health section, title rather. The title has now been changed to mental health and substance use disorder. So really highlighting that there's, you know, we have a substance use disorder crisis in this country right now, and that's not spoken about, and we're hitting numbers of overdose deaths that we've never hit before in this country, and that's a population, that's something that I think would be great to focus on next year, not putting anything on your plate, but add it to the list, but sorry, so that's something that I sort of saw as a place that could be bolstered a little bit in HEAA, and kind of, I think on that note, are there policies that are not included in HEAA that you all would like to see included next time around, or think there should be an added focus next Congress?
I know everybody's going to beat me up for saying it, but I'm going to say it out loud. We got to start looking at the trust fund. I'm sorry. The trust fund is running out of money in 2026. It's informing healthcare, right? CMS is running the program around an actuarial problem. And we shouldn't just leave them to try to suffer through that. And I know nobody wants to touch it, but at some moment, we've got to open the door in the trust fund and have a conversation about that, because that's how we pay for our healthcare. And we have a structured problem there for sure. Now, throw Medicaid in just because I have to.
Yeah.
Can I? Were you going to jump in? Yep.
Yeah, real quick. And I'll join you, Dr. Parker, because I'm probably going to get killed for saying what I'm about ready to say. I think we know that we have a major opioid crisis and a substance use crisis in this country. We do. But prior to, the Sackler family coming in, we've long had a pain management system issue, especially for racial and ethnic minorities. And so my concern has always been seeing the pendulum swing so far in the direction of keeping powerful pain relief meds out of the hands of folks who tend to get hooked, sometimes, not all the times, and move on to disastrous health outcomes. Because every time I turn around, I'm going through JAMA, there's another study about racial and ethnic minority Americans, Black and brown people, being denied access to adequate pain management because of implicit bias about how people of color are deemed as having a higher pain threshold or pill seeking. And the outcome on the back end is disastrous. And it's a conversation that if we're going to look at controlling the opioid and substance abuse epidemic in this country, we need to make sure that we're doing so. And we do. So don't get me wrong. I fully agree with that. But we need to make sure that we do so at the same time ensuring that racial and ethnic minorities and others that are discriminated against on often an implicit bias level aren't denied access to the quality health care that they not only need but deserve as human beings. And there was an article that just came out in JAMA, and it was really disheartening. And you guys can look it up, but they surveyed, it was 2019, they surveyed doctors and med school students who literally said that they thought that especially African-American and Latinos had less sophisticated nerve systems, that the darker your skin, the less likely you are to feel pain. And that has a direct, you can imagine if you're someone who's struggling with cancer, or you have a compound fracture in your femur, or you tear your Achilles and your doctor's telling you to go home, with a Flintstone vitamin and an aspirin, that's not quality health care. So just on the pain relief piece, I just want to make sure that I throw it out there to Congressman Barbara Lee Staffer. I apologize. When I get back to DC, I'll make you some scampi, but I think that that's a really important part to keep into the conversation too, because it's a very real problem. It's been around, but it's starting to emerge more and more in the research.
Yeah, I think that's a good point. And anyone else, other policies? Gloria, did you want to add anything? Policies that you think would be good to focus on next Congress for HEA?
Mine's is really quick. It's focused a little bit in Title 10, some of the other ones, but I think being more explicit about climate change is something that we need to think about when we think about the health of our community. So I know we're running out of time, so I will say that.
Yeah, I think that's right. And there are I came across an interesting study recently that was linking maternal health with in the environment and factors in the environment. And we all, as I mentioned, till my face is blue, that's something the Congressman cares a lot about. And so that's something our office is always keeping track of. So, so many more questions to talk about, so many more things that we could discuss, but I do want to give the audience here today a chance to ask questions if they have them. So if folks want to ask a question, you can come up to the mic and ask it, introduce yourself, and direct the question to a specific panelist or to all the panelists, and then we'll do about 5, the session started a little bit late, so we'll probably do 5 to 7 minutes of questions.
I'll try to be brief. I'm Reynold, Verret, President of Xavier. Question I have is on Dr. Puckrein, but to the others as well. In the bill, when we talk about clinical trials and access to clinical trials, there's a deep trust issue. And one of the issues that I think is a gap in the United States is that what will they do with my data? HIPAA does not protect in the same way. For example, the Boston College research case, which required the release of research subjects, broke that piece open. That even when the NIH, all of us program, which is asking for data, very intrusive, very intimate data about patients, right, does not have a clear protection as would be in the European system that says that the data cannot be used, for example, for insurance purposes, for other pieces that would be available through HIPAA. So is there a need for having a very clear demarcation of what that individualized data would be used for and what it cannot be used for that would help raise a trust issue? Because that is an issue not just in minority populations. Really, it's not clear, for example, what the data could be used with a certain court document. How do we protect that to make it available?
So I think your concerns are incredibly important. I think some clarity would be had if we made sure that it was clearly understood that the data actually belongs to the patient, right? And so that when it's being collected and used, people are informed that their data is being collected and used. There's technology now where we can anonymize data, because the conversation we're having is really a public health conversation. We're not trying to get down to the individual. We're trying to understand, I think there was a question earlier about a zip code. So when you look at a zip code, I can predict how many hospitalizations are going to be in a zip code. I mean, cardiovascular events, highly predictive. How many are going to go on dialysis? Highly predictive. All of those things are highly predictive. And I don't need to know the individual. What I need to understand is the circumstances around and the aggregate, how all of that works. And so, number one, we start with making sure that people own their own data and everybody clearly understands that. And then we can move to anonymizing the data to make sure that it's available, because at the public health level, that's where we want to get predictive. Data tells you about the past, the analytics tells you about the future.
Yeah, I think that's a good contribution. Are there any other questions from the audience that you all have? Feel free, don't be shy.
Hi, I'm Kathy Jackson, Senior Director of Advocacy with Mallinckrodt, one of the companies. I have a couple questions, actually. The first one really is, I've been a nurse for a long time, many decades, and we're having these same conversations that I had when I first started in nursing, to be honest with you, about health inequities. And what is it gonna really take to change? This has been we keep hearing this, and it's changed. And I was really intrigued by the idea that guidelines, because being in the healthcare system, actually help establish racism and inequities. I kind of would like to hear a little bit more about it, but I'd also like to hear is, what do you really think that has to happen to change? I mean, there's so many, I know this is a multi-factor problem, But where are we going to start hearing now people on the stage going, wow, look where we were and look where we are, you know, like we still have a long to go, but look how far we've come. I just have never heard that said about this issue. And I just get so discouraged, especially being within that healthcare system. Thank you.
We shouldn't be discouraged. I've been doing this a long time. We didn't have this conversation several years ago, right? The health disparities existed out there, and we started to have it back in 2003, but it's really taking shape now. And I think we're at an inflection point now where I think we can really do prepare ourselves for our future. On the clinical guidelines, we need to have good science on everyone, and we don't, right? We do our clinical trials. They're not diverse. They get generalized into the clinical guidelines, and it's in the practice where physicians realize that maybe that therapy doesn't work as well in this population or whatever. We can forestall that by getting greater diversity in our trials.
And also one lesson that we learned from COVID was that it was that trust issue that we were fighting against. So we really worked hard to make sure that the trusted messengers of the community, oftentimes community-based organizations, have the funding they need and they're involved from the get-go rather than having the funding to trickle down from states, maybe getting to the smaller organizations. So having direct federal funding to community-based organizations, I think was one step forward this time around and something that we should look at to embed in the future.
Yeah, and I think, just want to add something to that. I think one of the things that gave me hope was the Build Back Better Act and all the wonderful policies and how ambitious that piece of legislation is. And I think, although it's not, we're sort of taking a pause on that right now, I think that bill's out there, right? That bill is close, and so, or was close to being passed into law. So I think these are the conversations, and we're thinking a lot bigger now about these issues, and that encourages me. And I think seeing the president's real focus on health equity, like I think that's one of the first times. And one of the questions I didn't get to really talk about was, I think HEAA was introduced April 2020 April 2020, and that was before the murder of George Floyd and like this whole and others, and like just this huge social movement and huge attention to health equity in a way that I haven't seen before. And so that also gave me hope. So I think that there are glimpses of of hope here and there. And I think, of course, these conversations still kind of feel a little bit stale in some ways, but I think there's an increased consciousness about these issues that I think is a positive thing. But yes, I think we'll make this the final question.
I think Britt wanted to say something.
Oh, did Britt want to jump in?
Yeah, I just want to say to the gentlelady who stood up, I can't see you, who said she's been in nursing. First of all, thank you for your service. Let me just say that right now, hands down, thank you for your service. Yeah, and then the other piece, and I think that Congressman Lee's staff said it brilliantly, which is about the funding for a lot of these things and making sure that the entities that have the trust the community, that represent the community, that often employ people who live in the community, are integrally a part of these efforts at the ground level, and that there should be much greater attention. And we've been trying to do this for a long time to really stop entities from giving other organizations large sums of money, and then those organizations will sub-grant out smaller sums of money, but with like an 85% overhead. And so it's just a really disingenuous way for them to say, oh, we're doing something to check the box on equity, but in reality, they're not really doing much. And we've got so many great community-based organizations. We have to remember our minority serving institutions. We've got HBCUs, Hispanic serving institutions, Indian colleges and universities. These are all entities that should be receiving direct money from the government to really be a much stronger and much more just sort of integral part of the leadership of a lot of the efforts that we're talking about right now. And I think that I'm inspired that a lot of those conversations are happening. I know that when I first started, looking at this issue, and this was back in the early 90s, disparities was reduced to a pie chart in the margin of effect that said black, white, other, So it's nice that people are actually looking at populations much more differently, taking a look, upstream. And then the last point I do want to say is, to the gentlelady, the nurse warrior who talked, there is a book out that I read that blew my mind, and it talks exactly what you're talking about, and it's called The Political Determinants of Health. And I read it, and it really does look so far upstream and provides an even stronger pathway where we need to go as we move downstream. So I believe it's on Amazon, but it was really eye-opening when I read it. So I would just encourage, you to take, not to add more to your workload, but it is a good read. It's worth the time.
Thank you,
Can I say
Britt.
one quick thing?
Okay.
I also think, sorry, this is gonna be real quick and you can answer a question. I think we also should not downplay the impact of the Affordable Care Act. Yes, it's not just about access, but what the Affordable Care Act did for low income, minority, brown, and all sorts of population cannot be understated. And I do think we do not give the credit to that it's due. And so I just wanna throw that out there. And I think that's a real important, getting people access is vitally important to changing a lot of these things.
Yeah, that's right. And the millions of people who have healthcare now coverage who didn't before that bill was passed. I think that's a really good point. Yes, okay, final question. We're running a little bit late, so make it quick, please.
I'll keep it really quick. Sonia Clay with Nova Nordisk. I know that HEAA has a section on chronic diseases, and obviously we know that with COVID, chronic diseases played a really significant role in increasing people's vulnerability to COVID. So I'm just curious how HEAA, if there are any highlights within the current bill in terms of how chronic diseases are addressed either in prevention of or treatment of chronic diseases. And I want to, and this is a comment, I mean, I know that health equity has been a really significant priority both for Congress and the administration, but I haven't seen a lot in terms of addressing chronic diseases in terms of the discussions that have occurred in either the House or Senate. So those are my questions. Question and comment, yeah.
Someone who not.
I know, I'm gonna be real honest. Go ahead.
No.
I was gonna say, I know it is in the bill. Right now, as you said, it's like, what, 1,000 pages, and I can't remember the exact focus. I know that we have added some additional chronic diseases to be considered as one for disability populations or other things. I don't know the specifics. I don't know if Anita knows the specifics right now.
Yeah.
I can look it up and find it in that. Oh, Britt looks like.
Yeah, Title 7 expands the list of the chronic diseases. It does touch the chronic diseases that have been identified as sort of, pre-existing conditions that exacerbate COVID. There are some though that are missing, like lupus isn't mentioned. And, that just sort of struck me because this is an equity bill. We don't talk about lupus. So to your point, the young lady from Nova Nordisk, you're right. Discussions about chronic diseases, it's not that it's not important, it's vitally important, but I think that at this point, it's so woven throughout. When we think about all the other factors that lead to health inequities and health disparities, those numbers are the most profound among, sadly, almost every chronic condition in this country. But I do get what you're saying. There is a need to make sure that as these conversations continue, that chronic conditions that have been affecting racial and ethnic minorities and other populations that don't get enough attention are not falling to the wayside. But there is Title 7 specifically looks at that. There's mention of some of these issues in Title 4. But I do think that the point that you're raising is a great one. And, and obviously, as we're moving forward, if there's language you'd like to see in the next iteration, share it. There's room at the table, and you have a perspective that as a staffer, I know I still don't have. I never worked at a drug company, and I don't know that anybody else has that same perspective, but it's valid. And if there are things that you recommend, including that will make, to really push the health equity lens further in the direction, especially among those living with chronic diseases, among those who are caring for people with chronic diseases, among those at risk for a chronic disease, by all means, share that, because knowledge is power.
Yeah. I think that's a good way to end it, where, if there are things that aren't included in HEAA that you think would be appropriate to include in HEAA, I think as we have these conversations and continue to collaborate with Representative Barbara Lee's office, we can make sure all those things are included. And I think, as Britt mentioned, Title 7 is one of the largest titles in HEAA, and that includes a ton of different, covers different diseases from sickle cell to cardiovascular disease, and diabetes and that sort of thing, but also things that I had not expected, like circadian disorders, so sort of sleep disorders, and that's something I had done my research on in undergrad, so I didn't even think people knew what that was. So there is room for everything in HEAA, truly, so it's a huge collaborative effort. And with that, we did run a little bit long because we started a little bit later, so again, appreciate everyone's patience as we got started today, and I just want to kind of bring us back to some of the major highlights that were discussed at the panel this morning, and really thankful. This was a really robust discussion with folks who had different perspectives to bring to the table. So very thankful for your time, your expertise, your work, and continued support of HEAA. And so some of the things we touched on today were holistic care, really treating people, not only their health and the help they get at the doctor's office, but also, is everything okay? You guys are making faces? Okay. Not only as that the care folks get at the doctor's office, but also the social determinants of health and transportation, housing, that sort of thing. Also, we talked about the intersectionality of folks, how, yes, the bill is focused on racial and ethnic minorities, but really everyone kind of comes to the table with a different identity, and how we're becoming more inclusive in how we discuss HEAA and how we look at healthcare more generally. I liked what Erica had mentioned about lived experience, and how all of us here have lived experience to bring to the table, and that's really important, right? We live in these communities. These are our parents, our grandmas, our lives, so we have a lot to kind of bring to the table from that perspective. We had a really robust conversation on data collection, and how it's not just about data collection, but also, is that data getting reported to where it needs to go? Is the data, we didn't really talk about this as much, but is the data being shared across states? Is it being shared adequately with the federal government, that sort of thing? But also data analysis is important. You have all this chunk of data, but what do you do with it? And who has the education and the ability to analyze that data? So I think there were some excellent points that were kind of brought up today. I wish we could have talked for another hour. There was so much to talk about here, but I'm really looking forward to the rest of the panel, the rest of the panels today that we'll dig in a little bit deeper. So we'll have one on mental health, we'll have one on workforce diversity, and then we'll round it out with an all member panel. So thank you all for your time. We're gonna take a little break after this. Oh, and huge shout out to people, to Bree and Shahana on my staff. So I don't know where Bree is, but just really thankful for helping me to sort out the hybrid the hybrid panel technical difficulties. So thank you.
Hello, everybody. I'm going to ask that everybody come back to their seats so we can get started on panel 2. If you can make your way back to your seats. I wish my kids listened as well when the audience got so quiet. Okay, so in the interest of time, I'm going to go ahead and get started. Excuse me. Is the volume okay? Yes? Okay. So good morning, buenos días. Es un placer estar aquí con ustedes. It's a pleasure to be with all of you this morning. My name is Shahana Kozlovsky, and I'm a Spanish-speaking psychologist, and I've spent the last 20 years working with immigrant and migrant communities. And so our topic today is very near and dear to my heart, and we're here to talk about our second HEAA panel, which really focuses on no health without mental health equity. So really talking about the intersection of mental health and health equity. You are all likely familiar with the health equity concerns. Communities of color have less access to mental health resources due to the lack of a diverse mental health workforce, a lack of culturally and linguistically informed mental health providers, and a lack of coverage for mental health services. So dire is the situation that both President Biden and the Surgeon General raised the alarm related to mental health, children's mental health, and the need for a diverse workforce. Despite the challenges, there is reason for hope. We have a panel of experts here working on the front lines with mental health and communities of color, willing to share their insights on strategies we can use to close the equity gap. We have a room of interested participants looking at this topic from multiple angles, as providers, academics, industry professionals, policy experts, congressional leaders, and our hope for the future, students. We also have HEAA, a comprehensive health equity bill that offers policy solutions to close the equity gap. Some of HEAA's key mental health provisions include offering loan reimbursement programs for racially and ethnically diverse health profession students, offering financial incentives for individuals working in workforce shortage areas, ensuring that health professionals are trained to work with racially and ethnically diverse communities from culturally and linguistically and trauma-informed models, calls for increased focus on integrated care models that bring mental and medical health together so we can treat the mind and body holistically, and bringing mental health services to the communities, in schools, with unarmed alternative crisis response programs, and training peer support specialists and cultural healers to work with mental health issues. It is my hope that over our time together, you will learn about the important work this diverse set of experts is doing to address the intersection of mental health and equity, and you will leave feeling empowered and equipped to join us on our journey. Together, we can turn the tides and close the gap. Now, I'm going to offer a few brief introductions of our panelists, and then I'll have a set of targeted questions from our panelists, a little more open-ended questions, and I will leave time at the end for questions from the audience. I'm going to be doing introductions in alphabetical order in the interest of equity. And so that would place our health policy expert, Martha Kramer, first. So Martha Kramer is joining us from DC. She's a health policy advisor for Senator Ben Cardin of Maryland. Her portfolio includes domestic and global health, supporting Senator Cardin's work on the Senate Finance Committee and the Senate Foreign Relations Committee. Prior to joining Senator Cardin's staff, Ms. Kramer was a senior policy advisor for Congressman Earl Blumenauer, where her work focused on transforming care for patients with end-stage renal disease, improving end-of-life care, and advancing value-based insurance designs. Previously, Ms. Kramer worked for Congressman David Scott of Georgia, where her work focused on improving health equity. Ms. Kramer graduated from American University with a double major in international studies and history and is currently a JD candidate at Georgetown University. So you're very busy, Martha. Next, we'll be joined by Dr. Lucinda DeGrange. Can you raise your hand, please? Dr. DeGrange received her doctorate in psychology from Tulane University right here in New Orleans, where she completed a fellowship in forensics with an emphasis on child custody evaluations, and she has over 15 years of clinical experience working within a variety of settings, including private practice, hospital, elementary and secondary schools, Head Start, University Counseling Center, and family criminal courts. Dr. DeGrange also serves on several volunteer boards, including Odyssey House, Louisiana, and Addiction Treatment Center. We're also joined by Dr. Dana Lawson. Do you want to raise your hand? Who holds a degree in nursing practice from Old Dominion University and master's degrees in health administration and nursing, and a bachelor's degree in nursing biology and art history from Virginia Commonwealth University. Dr. Lawson has almost 20 years of experience in clinical nursing, managed care, clinical operations, health program design, and leadership. Currently, Dr. Lawson is the Vice President of Population Health and Clinical Operations, supporting the Louisiana Healthcare Connections Plan. This plan serves over 530,000 Medicaid enrollees, making it the largest managed care plan in the state of Louisiana. And lastly, but certainly not least, we have Dr. Brian Turner, who completed his undergraduate studies at the Southern University at Baton Rouge and his doctoral studies in clinical psychology at Jackson State University. Dr. Turner is the owner and operator of Moments of Truth, a private practice where he works as a licensed psychologist. He also serves as an associate professor right here in Xavier's campus in the Department of Psychology. His areas of expertise include reduction of mental health stigma, masculine identity, therapy and culture, and Black male experiences in higher education. Dr. Turner currently serves on the board for the Metropolitan Human Services District and the Arts Council of New Orleans. So I'm going to start with some targeted questions for each of us panelists to get us started. So I'd like to start with you, Dr. Turner. And I'm wondering if you can just discuss how health inequities in this country are impacting the mental health of communities of color.
All right, well, first, good morning. Thank you all. At the tail end of Mardi Gras week, where most of New Orleans is still recuperating and recovering, and yes, eating gumbo. One of the things I wanted to say, Lillian Comas Diaz authored a paper some time ago entitled The Ethnopolitical Approach to Working with People, towards Working with People of Color. And within that article, she talked about some of those kind of things. The three things she talked about was naming the terror, and that oftentimes within the mental health field, we don't really talk about the issues of the inequities around race and diversity and how that's not met. She then talked about the praxis in terms of how do we do that. And oftentimes, I'm charged now because I sat in on some of the first panel and I was listening, and she talked about how our training programs, our academic institutions, we don't have those conversations around how to work specifically with issues around culture. And I know the buzzword now is DEI, but I'm gonna be very simplistic today because I went to Mardi Gras and I rode in Zulu, so I'm trying to get my brain functioning for Monday at this point. But we have to be honest about what it means to talk about like people that are culturally different. And just because I'm a Black man doesn't mean every Black person I'm gonna work well with. So I have to constantly take myself to task to do that work, to work with people who may look like me, who may have the same gender as me, or whatever. And then the last part is like, we don't oftentimes create safe societies. We don't create these safe spaces for people to do this work. And so I'll be brief at this point. I remember I had a consultation when I was in Pensacola. A good friend who's a clinician, white male, asked me to come and kind of help him figure out why he wasn't retaining clients of color. Walk into his office that morning, I say, hey, how you doing? I just see Dr. So-and-so. Young lady never looked up and says, okay, have a seat. I'll let him know. I sat down, 15 minutes passed. I'm also getting paid for this, so I didn't care if I was sitting down. So I'm sitting down, I said, okay, well now I'm hungry, I wanna leave. So I said, hey, I'm Dr. Turner, I need to know what's going on. She looks up and her face kind of cracks and falls on the floor. I'm so sorry, I didn't know it was you. And I was like, well, there's no one else here. Who else did you expect? And so the office, I explained to my colleague, the walls were white, the pictures were white, the music was white, the magazines were white, his staff was white. I was like, well, that would make sense that if a person of color, a woman, a person of Spanish-speaking descent, anybody came to his office, they wouldn't feel very warm. And then the last thing I would say about what's happening is three things. It's the access to care, it's the quality of care, and it's the diversity of care. Oftentimes in a community of color, we don't have access. So my office is in the 8th Ward of New Orleans, Louisiana, in St. Roch. But a lot of providers are uptown on St. Charles Avenue or in places where Black people, communities of color can't get to easily, or it costs a lot to park there, right? Quality of care, oftentimes we have to be honest about the training. And so there's a diversity of people who provide services, but we have to know what people really need. As a licensed clinical psychologist, I would like to think I could work with everyone, but I don't want to, and I can't. So I have to know that when people come to me, my actual first thing to say is, I'll refer you if you want me to. Like, let me make sure you get what you need. And then the last thing, that diversity of care, we need to make sure that people have access to evaluations when they need. They need to have the medication providers when they need to. They need to have the diversity of, maybe they need family care. And so when we talk about these inequities, it's broad in the sense that Dr. Comas Diaz laid the foundation that we have to have a real strategy to how we do this work, but also have to think about how, what I heard on the panel before, but what are the policies saying about that, right? What's happening inside the insurance provision kit that we get, right? How does that actually happen? And I'm gonna stop there.
Thank you so much. What you talked about really resonated with me, and I just want to highlight that idea of the intercultural variability. And as you all know, if you've been working in the space in the old days, we had the recipe books. When you're working with Black people, you do this. When you're working with Latinx people, you do this. And what a disaster that was. And I really appreciate you highlighting that we are all unique individuals, and no one part of our identity defines us. I'm going to transition to Dr. DeGrange. I know you've been working a lot with children and in different settings, and I'm wondering if you can talk a little bit about what happens at that intersection between health equity, mental health for our children and our youth.
Thank you. Thank you for the question. And I really appreciate being included on the panel with such talented people. So it's an honor to be here. First of all, I'd like to talk about what the research tells us about child and adolescent mental health. And what the research says is that you have similar levels of mental health challenges in children and adolescents across racial areas. But what is problematic with racial and ethnic minority populations is there's a chronic element to the mental health challenges. And so you ask, well, why is that? What's happening to make that mental challenge stay? And certainly part of it is access. It's very important that children be able to access mental health treatment where they are, in communities, in schools. And it's also important to really understand that children are not in a bubble. They're a part of a family, and they're a part of a school. They're a part of a community. So you really need to have a population health approach to really impact children. Now, in my practice, I'm in private practice, but one aspect of my practice is that I contract with schools. So I'm able to go into schools and lead teams that do evaluations to determine whether or not a child qualifies for special education. And if they do qualify for special education, what's the best classification for that child? And so when I was thinking what I was going to talk about, I really wanted to bring home a specific example. And so this is an example of inequality that I see daily. So you have a white child, a white boy, that has behavioral challenges that are impacting his academics and that are impacting the class and other students in the class, and this child has ADHD. You have a black boy who has behavioral challenges that are impacting his academics, that are disrupting the classroom. So the behaviors are very, very similar. And let's say both children have a diagnosis of ADHD, or if one doesn't, as part of my evaluation, I may end up diagnosing the child with ADHD. And so now we have this very similar presentation. Now the question is, if the child does meet criteria for special education, what's the classification going to be? And so two of the classifications we're generally looking at when we see significant behavioral issues is other health impairment and emotionally disturbed. And now these different categories land very differently in schools. And what I see, and the research supports this finding, is that you have same behaviors, but the white child is diagnosed as other health impairment, and the black child is diagnosed as emotionally disturbed. So now let's talk about how those two classifications land in schools. When a teacher sees that a child is other health impaired due to ADHD, they're like, oh my goodness, this child has ADHD. So let me make sure I read the directions, more than once to make sure the child has it. Let me alert the child that I'm gonna say something important. Let me maybe give this child extended time. So there's various approaches that are done when you know a child has an other health impairment. And now we're looking at the child that's emotionally disturbed. And how that's received by a school is, we have to be on alert. This is a child that the teacher has to protect herself from and has to protect the rest of the class from, because the child is a problem. And I see this over and over again in schools. And this is a very simple example, but it has very long-term consequences from how that child views himself and how he's treated by the larger community. And there's also a chance, even if a child has average to above average intellectual abilities, they may actually be sidelined into a special needs class because their behaviors are so problematic that they can't be included in the class. And so they're not getting the same education. This is just an example of something that just really, really needs to change. And one other quick point that I see in schools when I go to work is children respond differently to people that look like them. There's just a comfort level there when you're evaluating them and if you're providing mental health services. So training culturally and linguistically diverse professionals is very important if we're concerned about the development of children.
Thank you. And that's such a, that example really hits home because early in my career, many years ago, I did work with foster youth. And I saw what you were saying, and I saw it a layer earlier where the diagnoses that are given are different, and that the white children were more likely to have the ADHD diagnoses, and the Black children were more likely either to have the oppositional defiant or the conduct disorder. And we all know conduct disorder is a diagnosis of death because it's not treatable, and it turns into antisocial. And so I think there's multiple layers to that their kids are not being diagnosed, or they're being diagnosed based on their race. So thank you. Right. Dr. Turner and Dr. DeGrange, you've done such a great job of highlighting kind of the intersection of mental health and health equity for children and for individuals. And now I'm hoping to turn to you, Dr. Lawson, and get a little feedback more on the community level. And I'd really love to hear a little bit more about what you see in your community space on the intersection of health equities and mental health issues. How do these issues manifest themselves at the community level? And how do these issues impact care delivery?
Sure. Well, thank you, first of all, for the opportunity. As you mentioned before, Louisiana Healthcare Connections has over 530,000 members in this state for Medicaid. So these are our aunties, our grandmothers, our neighbors, our churchgoers. And so, the work that we do is really impacting the individuals that live here. In my experience, I've been, with this company for a year and a half now, and have really gotten to know Louisiana, coming from Virginia. And one thing that I've noticed, and that our experiences show, is that this is a tremendously resilient state. With a lot of the traumas that communities of color have endured in the history of this country, they still press on. One thing that we find, and one thing that we do take to heart, because we are a locally based national company, in the words of one of our famous patient advocates, Valerie Billingham, she always says, "Nothing about me without me." So take a minute and let that sink in. Nothing about me without me. And we have a responsibility to better partner with our communities, with those formal and informal leaders who are already doing this work. I have teams of community health workers, peer support specialists who we recruit from the communities that we serve. And so they are a rich source of information in letting us know where are the gaps, where are we falling short as a system, where are we failing, but also where are the successes? How can we build upon those successes? And so that is our approach. Now, kind of going back to the monster in the room, when COVID-19 hit, as we were, getting back out there in the community, meeting members where they live, in their homes, wherever that is, it put a stop to it, right? We could no longer visit people in their homes. We could no longer visit them in the hospital. It really did impact how we were able to outreach and engage people in ways that they want to be outreached and engaged. And so as things started opening up again, the data shows, of course, the tremendous impact that this pandemic has had on people's mental health. In this state, we were able to open up crisis services, and prior to the pandemic, very minimal usage. When the pandemic hit, it increased to over 250%. And so this is something that has been ongoing, but now all the covers are removed. And so now what are we going to do about it going forward? And what we're doing now, as we're starting to get back into the community, getting back in front, of members and families, we have to say, listen, I appreciate what the panel said in the beginning about building more chairs around the table. I think a lot of times when you have, a national footprint, we come in with our fancy data packages, we come in with our fancy programming and folks with credentials, and we say, oh, we know what your issues are, we got the solution for you. And communities of color who have, experienced tremendous trauma and mistreatment in this country, they want nothing to do with it, and rightfully so. And so you can't go into a community and start diagnosing and treating without, first of all, saying, well, what are your priorities? What do you identify is an issue for you? How can we partner? And then empowering that community to carry on the work, because a lot of times, you may come in with a parachute effect and you come in with everything, you say, oh, my work is done, we're out. And then the community is no better off than before you came. So, we're very intentional in that. I know you're going to get to additional questions later on in this panel about building that workforce pipeline from the communities that we serve, partnering, with Xavier and other institutes of higher learning, to really encourage this next generation of healthcare professionals to do the work that is ongoing and needs to continue.
Thank you so much. I really appreciate each of our panelists bringing to life the data and the stats. Now with this audience, I know we don't necessarily need to do that because many of you have had these experiences either professionally or personally, but I think it's still important as part of bringing all the voices to the table. I always like to make sure we're not just talking about numbers, we're also talking about people. And so the stories you've shared really stay with me and hopefully will stay with you. I'm going to pivot a little bit right now, and I'd like to call on Ms. Kramer to talk a little bit at the policy level. Ms. Kramer, I wanted to see if you could talk to us a little bit about what Congress is doing right now to address the mental health concerns in the context of health equity. What do you see is the activity on the Hill and on the Senate side? Actually, you offer a unique perspective having worked on both sides of the Hill. So tell us a little bit about the activity up there.
Yes, thank you for the question. I'm glad to be a part of the panel. Leading off of some of the discussion from the previous panelists, I think, the nation is noticing the need for mental health care in a way that we haven't sort of discussed it previously. The president spoke about it in the State of the Union. The Surgeon General put out an alert in December. So there's a heightened interest in the topic, and that is reflected on Capitol Hill. I think every committee that has healthcare jurisdiction has had a hearing regarding mental health in just the last few months. So there's a clear interest to take it up in the Senate Finance Committee, which my boss is a member of. We have a bipartisan working group to develop legislation. The Senate Health Committee also has a working group they're putting, or sort of a process that they're putting together. And on the House side, there's been a number of hearings in the Energy and Commerce Committee, the Ways and Means Committee, and the Education and Labor Committee. So all the committees that we would need on board to address the different levels of need. I think, one thing that on Capitol Hill is that it's often a reflection of the nation. So, historically, health equity has been really championed by the Tri-Caucus and, select members. And after 2020 with the pandemic, the racial reckoning, we've seen a heightened interest across the Congress. And so there's been an interest in infusing the work that we do on mental health this time with health equity. And I think, that's highlighted some opportunities and challenges. I think, one great thing about HEAA is that it really is a comprehensive collection of policies that policymakers have worked on for a long time. That's, a collaboration with communities that we are a part of, we work in. And so it brings a lot of influence to the conversation. But there are a lot of members who, are newer. Maybe, they haven't worked as closely with community partners, and so aren't used to, they don't have that relationship. They don't know how to bring them to the table. Additionally, I think, Congress is, a traditional institution. And so we traditionally work on issues that have been on the long term. And so I think we're seeing some tension around, policies that folks have worked on for a long time that, maybe they didn't take equity into account when they were putting the policy together, but still want to get it passed in this sort of context. So, I think there's a lot of learning that's still going on for a lot of members. So, we can talk a little bit about that more in the discussion phase, but I think, overall, there's a lot of interest and there's activity going on, but there's still challenges. So happy to talk through them more during the discussion. Thank you.
Thank you. That was really helpful. And I appreciate your balanced approach, that there's a lot of discussion and activity, but there's also issues. And I think that's a great approach. So now I'm going to open it up to some more open-ended questions for anyone on the panel. And so a number of people, mentioned the need for having more culturally and linguistically diverse workforce. And so I'm wondering if anybody has, and I should just ask Xavier's president, because apparently you all are doing a great job on graduating Black pre-med students, but I'll turn to the panel for right now. What do we need to do to support racially and ethnically diverse individuals and recruit them into the health professions fields? What are the thoughts you have on how we can close that gap related to mental health?
Money. Well, I'll say this and I'll get out the way because this is a conversation I'm having regularly with students here. We have to ask policymakers not just to make policies about what people should do, but they have to make policies about how we can do it. And what I mean by saying that is that I regularly find barriers to getting funding for things or having access to things that would be really great here because I'm not at Tulane or I'm not at whatever institution. Now we work through it, right? We make ways, and fortunately, the Sisters of Blessed Sacrament believed in doing more with less, and we're trying to address that by doing more with more. But oftentimes, that's our biggest barrier. We're in a space where our students have the same capacities, the same abilities, but we have to ensure that policymakers are ensuring the same provisions. We have the vision, but we have to have the provision. We have to have the relationships. It was great that a couple years ago we were able to get our loans forgiven from Katrina, right? It's great that we're able to get these things that help us. But at the end of the day, if Congress and policymakers are not going to look at being equitable in the providing of funds, that's going to constantly be the barrier. And I'm going to say that and I'll be done.
And I'm going to piggyback on this funding issue that Dr. Turner brought up. I'm very heartened to see how here at Xavier, we see additional programs being added in the health space. I was speaking with the provost last night, and we were talking about how at Xavier, there's now a physician assistant program. And so this is how you do it. You have to have the programs where the people are. And so having the programs at HBCUs, that's great. And then also in public universities, you have to let people in to the graduate programs. I was just speaking with a friend of my son's that is a speech language pathologist. And she was talking about the very low representation of Black people that are in speech, that are speech language pathologists. And she was talking about access to the graduate programs and what places she can get in. You fund these places, create more spots so that people of color can be educated, and so you can have a professional workforce.
There's a master's program in speech language pathology here at Xavier also.
That's the way to go.
And I'll piggyback off of what both the good doctors have said, and I'll take it a little step further, and I'll talk about the internship and mentorship opportunities that students have to be exposed to in their formative development. And I think a lot of times, especially, I'm an advanced practice nurse, clinical nurse specialist, and never in any of my undergrad, grad, or doctoral programs was I exposed to the non-clinical side, right? And so, in managed care organizations like Louisiana Healthcare Connections, other non-clinical spaces, these are places where students should also be exposed. They can make a tremendous difference. When I was in practice, I was impacting members and families. But on this side of it now, you have an opportunity to really impact communities, states and generations of individuals and communities. And so we really do have to create these partnerships with, higher learning institutions to bring students on, let them experience what it is that we do, because we need them. I thank goodness for Xavier. I just, went through a bunch of student applicants, and it is awesome to see, the interest that is being generated to come on this side, of the aisle, and to really see it from our perspective when you're talking about, population health and developing health programs that impacts communities, having that experience and having them exposed to it early in their development as professionals themselves will really help to generate that pipeline, that interest to keep this work ongoing.
I got one other little point. So, and it was prompted by this point here. We actually have to hold programs accountable for actually infusing the diversity work in their training programs, right? And so what that means is you can't just get one class on diversity, right? You can't just be in one space where the diversity question appears and everybody knows the answer because it's just one question. And so we have to, and I know we're going to talk about this a little bit more, but we have to think about when we talk workforce, these leading institutions that continue to lead in terms of getting research funding and getting funding for whatever it might be, are they holding their feet to fire around actually doing the work around culturally inclusive, culturally sensitive, whatever you want to call it, work? And if we don't do that, then they're going to keep skating. They're going to always be able to bean count and say they did it, but at the end of the day, nothing is changing.
Thank you. Martha, I'm going to ask you a question. You're better versed in policy than I am, and one question that comes to my mind is, I feel like a lot of the legislation I've seen is really focused on graduate education, but as Xavier knows, and as you mentioned, Dr. Lawson, we really need to start in high school. We need to start in undergrad, because they're never going to get to graduate school if they're not getting exposed and get it supported earlier on. Are you aware of legislation that specifically targets increasing, diverse enrollment at the undergraduate level?
I can't say I can think of a specific policy, though I'm sure it exists. I will say I'm not an expert in education policy, so I can't speak to a specific policy. I apologize.
Oh, no worries at all. It's just given me pause to think. When I get back to the office, I'll look. But I think it's something for us to be thinking about, because I feel like I've seen quite a bit at the graduate level.
So there are programs. So there's the McNair program. The NMQF used to have a program when I was at Jackson State. But what I continuously find is in those programs, the funding is very limited, and mental health is still oftentimes on the outskirts of that funding, right? So, and once again, we at Xavier, we're part of the Build Pathways grant, right? And we get great funding for that. But oftentimes my research, I have to carve out a little something different so that I can make sure I get that funding, which while it's still central to the work I do, the focus is about oftentimes intervention, and that may not always fall within the realm of the biomedical field, right? And so sometimes I have to, carve out a niche, make it look sexy for someone who's funding it, but that's hard sometimes, and students don't always have that interest. And sometimes it's in a meeting in my office where I have to explain, hey, we're gonna say it this way so that we can get you to the conference, so we can get you a publication, right? And that's hard, and so oftentimes there is funding, but we're not always very specific around just mental health and how that space in and of itself is funded. So I don't want to make it sound like there's nothing, so I want to be fair, but we have to be honest that sometimes we're being, as I said earlier, pushed to the outskirts a little bit sometimes, and that doesn't help.
Thank you.
And I just to comment on that point, I think one challenge as policymakers that we have is, the sort of tension between integrating mental health care into sort of the broader healthcare versus sort of singling it out so that it can get specific support. And I think that tension, you'll notice we make different choices in different programs. And I don't know that we'll sort of find the right balance. I think that's going to continue to be an issue as long as we have constrained resources.
I really appreciate you bringing up that distinction, and I'd like to pivot back to our panel and really, can we talk about why is it important that mental health and overall health are integrated? Why, especially with communities of color? You seem pretty excited. Can you chime in and tell us why we need to have the mind and body together?
Oh, you just, thank you, Martha, for opening up that floodgate. I was waiting to be able to pivot. So, I think part of the great work, again, trying to, eradicate disparities in the mental health space is really and truly working towards physical and behavioral health integration. And I know sometimes we think about integration and we say, we're going to bring two groups of, the members' physical issues and their mental health issues, and we're going to address them on the same treatment plan, care plan. But when you really truly talk about integration, when you're talking at that individual level, you are really empowering and providing resources to providers, to the good doctors on this panel, to your PCPs, your pediatric practices, your OBGYN clinics, your FQHCs, who may be providing these primary services, but you're also bringing that behavioral health component. So members or individuals who have those issues have a more holistic team approach instead of creating these silos of care, which is what it is. If they go to their PCP, the PCP may refer them to a licensed mental health professional, and sometimes they talk, sometimes they don't. And so to the detriment of that individual, we're never treating that person holistically. So at the health plan level, at the systems level, this is where we are really looking at partners across the state to bring mental health services to primary care and pediatric practices, and looking at our behavioral health facilities and bringing primary care there. Because we figure if a member is coming in to get a health need addressed, they should get all of their health needs addressed at the same time. Make it fair, make it accessible for them to have all of their healthcare needs taken care of. And then on the other front, providing those class services. We just received our multicultural health distinction from NCQA. And what that will allow us to do is to, again, provide funding, provide education, support, and resources to our provider partners to be able to more holistically care for diverse individuals and communities. It is very early in its work, but I think it really does give the credibility and the attention that it deserves for people who are crying out for help. They want the help, but they want help from individuals who they can identify with. And again, that is a gap. We can do so much better. I think we have some success stories, but we need more successes than the failures.
And I'd like to piggyback on this point. Even when an individual is referred for mental health care, I think it's important to visualize mental health care as comprehensive. So what I often see in schools especially, you'll have young people that are getting psychopharmacology treatment. So they get medication, but the research tells us that the best approach is going to be the medication along with psychotherapy. And that's what we really need to move towards, instead of just this pharmacological approach to mental health.
Absolutely. And I'll just to tag on that, you know, as we are building on care plans strictly from a care management perspective, you know, this is where the true integration happens, right? You know, when you're able to talk to the psychiatrist prescribing, when you're able to talk to, you know, that mental health rehabilitation provider, when you're able to talk to the PCP, and you bring all of those collective elements into that treatment plan, and then you have an interdisciplinary care team who is reviewing this care plan and saying, their labs aren't supporting the use of this medication, but yet, you know, their intensive rehab program is. So maybe the medication isn't the answer. Maybe we need to go more on the therapy side. And so, you know, these are things that we have been, you know, at this level anyway, that, you know, is a success, because we are starting to have those conversations. We need to have more of those conversations, but we're starting to have them. And I think as we start bringing, you know, the collective teams together, and we start working off of one care plan, we start talking to each other, this is how lives are changed. This is how people start to, again, get the holistic and the quality care that they're desiring and that they deserve.
Yeah, and I would argue this is particularly important for communities of color, because there was a time when 50% of primary care visits had to do with mental health. And when you think about the stigma that goes along with mental health, we know that our community of color are not going to be seeking out mental health providers. I know the community I work with, no estoy loca, I'm not crazy, I'm not going to see a shrink.
And you know, if you approach it as prevention, that's an approach that's not rejected. So if you have in a community, if you have a community-based approach, such as even something like recreational sports, if you have communities that have a strong recreational sports programs, this is an opportunity to get mental health treatment. And also in schools, you can have school-wide programs that emphasize, for example, pro-social behavior. And all of the children are getting it. And so if we can view mental health in a broad view and really emphasize prevention. You know, we don't want to get rid of crisis treatment. That's definitely necessary. But if there are ways of preventing crisis, that's a way to go.
So if I could give you a data point, post Hurricane Katrina in New Orleans, Louisiana, most middle schools in New Orleans have gone away. Most middle schools in New Orleans provided athletic programs for would have been the 12 to 14, 11 to 15-year-old African-American male population. That population right now is one of the growing populations that are committing crime in our city. If they had sports, if they had that access, our park programs, we had a thriving program of athletic programs in our NORD program. I'll stay away from the politics because I do like my mayor, but NORD-C became a foundation as opposed to a government agency. So now we see the funding and the provision of opportunities like such, which as a former athlete, high school and college, you learn pro-social behaviors, you learn conflict resolution, you learn problem solving, you have a physical health aspect to those things that help to do what? Address mental health opportunities to what work things out. So sometimes it's not even a policy thing at the highest level. Sometimes it's local, but we have to be honest about what are the things that are affecting communities and why we're not working through these things. So when you take those things from communities, maybe that football coach wasn't a licensed clinical psychologist, but he was a healthy, thriving father figure in a community that gave that young man or those young ladies access to somebody to talk to. So everybody don't have to have a PhD to do this work.
That's right.
That is very true. That is very true. Some of the strongest and best interventionists are in the community or in the families.
Yes, those trusted messengers, you know, again, you know, that auntie, you know, in the church, or your nail salon tech, or your barber, you know, so many individuals who, again, folks trust, you know, they listen to them. They are that ear and that voice of wisdom, where the PhDs and the credentials can never get to. We can't. We can't penetrate.
I just thought about something. So look, this is a Friday. I usually don't do panels and suits on Fridays. I usually come in jeans, some J's, and a polo or a t-shirt, because most of the time, this is the end of the week. But what I also think about is that's also where I do a lot of my connections. I haven't been to a barber shop in about 20 years. Don't ask me why. But I usually make my connections with various people in the community, and that's why I say, hey, if you ever know anybody, any psychologists, here's my card. Holler at me. We'll see what we could do.
You're highlighting two really important points that are provisions in HEAA. So I'm wondering, one of them has to do with bringing services to the community, either through school-based services, through mobile health clinics, and the other is training peer specialists. And so I'm wondering if any of you can share a success story of a time when you are able to meet the needs of the community by bringing the services to them in any of those formats.
So I think, speaking from the health plan level, we did have a gentleman here in Louisiana that, frequently in the ED, frequently in the hospital, history of depression and anxiety and, plethora of other physical health issues. And we had tried for over a year and a half to get in touch with this gentleman. We would do, visits to his home, try to meet him, at his doctor's appointments, try to catch him after the ED. And I tell you, he gave us a run for our money. But after about a year and a half, one of our peer support specialists was able to reach out. They did their work. They found out who his treating providers are. She made connection with those individuals and finally caught up with him in a supermarket. And he answered the phone for 30 seconds. And he told her, if you want me, come find me. This is the store that I'm in. And she got in her car and ran to the grocery store and spent the next hour and a half helping him grocery shop. Didn't talk anything about his health, him going back and forth into the emergency room or the hospital, but she helped him shop. And that changed that whole dynamic, because now he has a PCP, he is getting treatment for his depression and his anxiety. He is no longer homeless, he is in transitional housing, and his quality of life has greatly improved. But with that being said, these are the folks that we need more of. These are the folks that we need to build a pipeline for, because they can reach, again, as we have said this multiple times on this panel, they can reach folks in the community and the communities that we serve better than we ever could. And so I think, again, creating that workforce pipeline, partnering with them on common sense solutions that will work, that have worked. We just need to scale it and sustain it over time. Again, not have that parachute effect coming in and dropping resources and leaving, but really helping to stand that community up and really engaging these trusted messengers, your pharmacists, my colleagues sitting, in the audience. Dr. Netter, is our VP of Pharmacy and has done tremendous work on that side. And just bringing these folks to the table, tapping into their wisdom and their experience to really reach people where they are.
Chester Pierce has an article called Offensive Mechanisms, and he talks about it in Street Therapists. And so one of the things I think about when we think about how do we do this, we have to call ourselves to come out of our ivory towers. And so I take myself to task. Sometimes I get in trouble because I may overbook myself, but that's why I serve on various boards and committees. That's also why I try to do as many community-based events as I can, both as a member of the Xavier community, but also as a private practice clinician. And so what I oftentimes think about, if we really want to change the work, and then we've had this conversation here at Xavier oftentimes around the blessing and the curse of being a person of color in these positions of like professional rank and privilege. And while sometimes it does become a little overbearing and I can go home and cry and stuff, but it is what it is, right? No, I'm fine. I'm just playing. I don't be crying. I'll be crying. But I do. I really do, actually. I was trying to keep the, tough thing. But what happens is like it actually becomes very, it's very like pleasing, because when I see young men and young women I've worked with that were like tough and hard at some point, I'll see them later and they're doing well. And so I'm reminded that oftentimes I ask for time away from campus. I have to make sure my schedule fits some of my outside activities so that I can be in multiple places at different times. And so I remember that I'll use this one little thing, and I had this conversation, and this wasn't at Xavier, this was at a previous institution I worked at, and my director asked me one time, she said, well, you don't tend to tell me enough about what you're doing. I was like, what do you mean? She says, well, I was in this meeting and someone started to tell me about all this stuff you were doing. I was like, okay, well, did I do something wrong? She said, no, it's all great stuff. I said, so what you mad for? And she's like, what do you mean? I was like, well, you hired me to be great. I'm being great. Leave me alone. I was like, I can't tell you everything I'm doing because I don't know everything I'm going to be doing. Some days I wake up and I just want to be average. The world won't let me be average. So I have to go and be great. But the point is, I remind myself every day to call myself out of my ivory tower. I hate the pandemic. I'm glad you said that because I can't walk around campus like I used to. So I used to love to just pop up in people's offices like, hey, I'm Dr. Turner. If I send a student over here, you better take care of them. Like, I can't just drive around the city and do other stuff. But that's the thing I would say to us professionals, and my joke is oftentimes if you go to Walmart, I never ask the person at the door a lot of questions because they're just greeting me. Not to diminish them, but they're the greeter. I'm gonna ask the pharmacist every question I have. That person gonna get that work. Like when I have to go to Walmart for my mom. So when I go there today, I got all kind of questions about this medication I'm picking up because that's the person with the degree. So I expect the person with the degree to do more work, have more information, and to give me more knowledge because that's what they do. And we have to call ourselves to that. So I put that back on my colleagues and my friends that when we step out, like we gotta give up some of those executive lunches and trips and stuff, and we gotta go to the hood.
And
That's right.
a quick addition to peer counseling, although I really did enjoy that.
It's all good, it's all good.
Talk. Just a quick addition to peer counseling. I'm on the board of Odyssey House, Louisiana, so it's an addiction treatment center. And the model for treating addiction, which is, has seen a lot of success, is former folks that experienced addiction are very effective with helping to mentor folks that are currently experiencing addiction. So it's that peer-to-peer interaction that's been very effective.
It is, and it's backed by, the data tells the story. We have a peer support program, and we found that individuals who have gone through that program are 84% more likely to engage in some type of substance use treatment versus 51% of those individuals who don't engage with a peer support specialist. So this is where the resources and the funding is going to bring more of them on board. They can help in a plethora of mental health issues, from crisis to substance use and pregnancy, just a whole gamut of mental health issues. And, again, bringing up and training the next workforce.
Thank you. I'm aware of time, and I know we had a late start, so I'm hoping we can go over just a couple minutes, but I want to move us along. I did want to recognize Dr. Ashley Netter, who I just learned about last night, and she's a community pharmacist. And so I was wondering, I told you I would do this, so I'm going to put you on the spot here. But, first of all, pharmacists, clinical pharmacists, you've been on the front lines of COVID. And I really believe that the reasons that we have the vaccine rates we do is because of you, because people weren't coming into our offices and listening to people in white coats, and it was you all in the communities and the pharmacies. So thank you, because our vaccination rates are pretty good. But I'm wondering, from a mental health perspective, I know you shared with me some stories last night, if you can talk about the importance of having pharmacists in the communities. What are the strategies you're using to engage the communities? And
I am very intentional about making sure that I'm relevant to that particular person. Oftentimes in a community setting, you're the person that they see the most often, whether they're coming in to treat a cold for their little girl, or if they're there to get some icy hot for the grandmother because she has joint pain. And when you constantly see them coming in, just saying, hey, how you doing? How's that little girl? How is your grandmother doing? Creating a relationship from not just transactional, but to being personal. So once you establish those relationships, one example that I can speak about is one triggered me was with substance abuse and pregnancy. So I had a patient that would come in often and she would pick up anti-anxiety medication. And so in our relationships, just commonalities of her coming in, we found that there were certain TV shows we liked and certain foods that we liked, and me being from New Orleans, talking about the second lines and all of these different things. And then I discovered that she was pregnant because the prescription came through. And so I just was honest with her and I was like, listen, you know, I care about you as the person. And if there's anything that you need from me as a person to get you the resources that you need because you have a baby, let me know. And in that transition, something shifted in her. And she was like, can we talk? And so she gave me the history of why she was on those medications and the trauma of Katrina and losing everything and feeling as though there was no way out but medication, because she could not have the access or that cry out for help because people didn't understand. They didn't understand. And in that process, it became me being able to connect her with the resources, with the women's shelters and opportunities that I can filter through Walgreens and other community partnerships that I had. And in that process, she ended up having a healthy baby. She ended up getting the resources that she needed. And it even got to a point where they placed her in another neighborhood where she could no longer come see me, but she would call me all the time, send me pictures of the baby, or if she had a ride, she would come by and just drop by and just say, hey, you know, and she would introduce, that's my pharmacist, y'all. And so those types of things, creating that relevance and really creating a space of vulnerability, you know, connecting with them with the things that are important to them helps with managing and creating those spaces where you not only identify with them, but you take away the stigma of being on the crazy pills, or, you know, they're a little touch, changing the vocabulary, something as simple as whether it being a psychotropic drug or something like that, but just saying it helps with your mood. They can identify with that. Or if it's something just as simple as, you know, sometimes I go through that too. You know, I have those moments where, you know, I may feel as though I'm a little down and I don't know why. You know, just connecting in those ways and explaining how these medications can kind of help to stabilize. How when you take these medications, how you're able to be socially responsive and not necessarily be stuck. So it's just recognizing those things and tailoring and personalizing that experience to make it relevant to them, so.
Thank you, and thank you for
And I'll
sharing
say,
that
oh, I'm sorry.
spontaneously.
No, I was just going to piggyback. So I hope, you know, from this panel discussion and throughout the day, you know, as we start to talk about, you know, how could we solve these issues? You solve these issues with the human factor. You solve it with the human factor. It could be us. You know, we have periods of anxiety. We experience periods of depression and, you know, and coming up on Louisiana, hurricane season is about to start here.
Oh, really?
So start, you know, in May. And so this is a time for folks living on the Gulf Coast that we start to feel some anxiety because it's like, oh my goodness, is this going to be another Laura? Is it going to be another Ida? And, you know, that plays into, you know, our everyday living. And so, you know, again, when you have folks who look like us, who talk like us, who have these lived experiences as we do, it makes that much easier. That's an inroad with us. And so that's how we solve these issues. You solve it through the human factor. You solve it through connection. You solve it through, you know, humility and compassion. And if that drives the work, it will get done.
So what I was going to say, Dr. Nutt, I don't know where you got that from, but that's the blessing and the curse that all too often people of color carry that burden of having to have that cultural homogeny and approach, right?
Yep.
The reality is that we have to call our white brothers and sisters in this space to task to do the same thing.
Yeah.
Because all too often we know there's only so many percentages of people of color doing this work directly. So I know, and I'll go back and reference that consult I did was he was a good friend of mine. And I told him, I said, bro, Black people are not going to keep coming here. Gay people are not going to keep coming here because they don't feel cared for. You could be the best psychologist in the world, but if you are not warm and inviting to people that don't look like you, don't think like you, they're going to stop coming. And there's nothing you do. So there's a piece of that we have to say, go back to the training model and the funding. We have to create spaces where at HBCUs, we're providing opportunities to get that funding, and then in our leading institutions, we're holding their feet to the fire to train their clinicians and providers to do that work and to be aware. And if they don't, they shouldn't get out. That's why I'm really happy that med schools have increased the role of psychology in getting the MCAT, so I have a lot more students in my department because of that.
I'm going to start to wrap us up in the interest of time, but I'm going to say when your Mexican grandma brings you a tamale in session, you eat it. You don't say, I'm on a diet, you eat the tamale. So you want to be culturally informed. I'm going to ask one final question for our panelists, and then I'll open it up for discussion. And I'm going to actually start with Marta, and I'm going to have kind of a call to action. And I'm going to say, Marta, what are the recommendations that you have for our community members here, our audience members here, about what they can do to kind of push the needle with respect to mental health and health equity on Capitol Hill?
Yeah, so I would say, please keep doing the work you're doing. And if you can, if you have the resources, come talk to members of Congress, I think, and, lift your voice in the organizations that you're a part of. I think, one thing that's really hard is for people who are building new relationships with communities. Maybe they haven't worked as closely with previously, or they've never sort of really worked closely on broader policies. They've maybe been working more narrowly on, sort of health equity specific policies rather than embedding health equity in sort of their broader policy work. And so, it's a hard process. They'll be learning as well, but please don't give up on us, and also continue to hold Congress accountable. I think, it's easy to kind of fall back into the status quo, and so I hate to ask people to do extra work to get Congress to do our work, and you always will have, the champions of HEAA behind you, but getting our other colleagues to join, I'll just have to ask you to keep up the good work. And then the last thing that I'll say is, the policy making process is a long one. I think our communities are familiar with long, hard fights. And so I'm hopeful that this, starts the process, but that we can sort of continue. And I think, there's been more acknowledgement of HBCUs, MSIs. And so I think as we, put resources in those institutions, I think it'll create sort of more of a feedback loop. But I hope folks, don't give up on us if we don't get things done this year or next year. But I don't expect you would. But I think that it's going to continue to be a challenge. So thank you for inviting me. And yeah.
Thank you. And so in 2 or 3 sentences, I'd like each of you, if you can offer something that gives you hope and on those days when you're kind of feeling down, what gives you hope to move forward really in this space, health equity and mental health?
What I've been thinking about while we're having this conversation, and the pharmacist spoke with just this wonderful story of showing interest and asking questions. I think that's something that we can all do, is be kind. That kindness has an impact on people for mental health. And if we just all made the decision that we were going to be kind, we were going to search to find something pleasant to say to the people that we encounter on a daily basis, it will not only make the people around you feel better, empowered, seen, but it also makes you feel good, like you're doing something for society.
Thank you. Sure.
So, well, first, I want to just go ahead and thank My fellow JAG, Aeneas Williams, for being a part of this issue in the building. Thank my Xavier family for hosting and giving us this forum and this opportunity. And thank everyone for being here. Obviously, you know, this work is important to us. So sometimes I think we preach choir to pastor, and sometimes we have to my next point, we have to get outside of that. So what I oftentimes do, and I'm reminded coming out of Black History Month, is that I'm not ever gonna have any dogs turned on me. I don't have any hoses being turned on me. So I call myself to the work, and I'm gonna just give that same charge that we have to remind ourselves, sometimes we gotta take off our suits and nice clothes and go and sit in circles and sit in spaces with people who may not look, think, or feel like us, because it's in that moment, like Dr. Anita alluded to, that people will realize that we're really there for them, and then they will actually embrace the work we do. So just remind ourselves, we didn't really come into this work to not be with people. So go back to the people.
Yeah, and you know, again, thank you for the opportunity. You know, this is encouraging. You know, these are conversations that may not always feel good, but they're necessary for change, for true transformative change to take place. And I remain encouraged. I remain encouraged by the individuals and the communities that we serve, despite some of the horrific incidences that have happened. They still have a seed of hope. And that's a trust that we cannot afford to overlook or abuse, but to treat it for the treasure that it is, that when we do have a seat at the table, that we are consistent, that we truly do show up, and that we always practice with an air of compassion and humility. And so I think, you know, as we turn the conversation, we start looking at the positive, start looking at the advances that we have made, start looking at the success stories that we can capitalize upon, and bring more of those to the table so that we can show that steps are being taken, and hopefully one day leaps and bounds will be taken.
Thank you. Right now I'd like to turn to the audience, and I'd like to invite, if anyone has any questions, to come to the microphone and ask our panel any remaining questions related to mental health and health equity.
Thank you for the opportunity. My name is Shurfi Guindo. I'm an executive at Biogen. Biogen is a biotech company up in Boston. And I really enjoy this exchange. However, I miss one point, the role of the private sector. Right? You mentioned scholarships, internships, partnerships. And I really think we as private sector, we have a role that we can play, that we must play in helping in talent development, developing diverse talent, the bench that we've talked about. You know, I'll just give you one example. I don't want to brag about what we do because we're far from where we want to go. And it's really not unique to my company. I think all the private sector companies represented here really ought to take this seriously and do more than we have been doing. Just 4 years ago, when I joined this company, I realized that we were not doing what we ought to be doing in clinical trials, diversifying clinical trials, especially in mental health and neuroscience. And we started to look at the barriers, right? Of course, a lot of it has been talked about today, but fundamentally, it is about having people who care, people who listen, who go into the communities where diverse populations, Blacks, Latinx, Native Americans, Asia, Pacific Islander communities are, and really understanding, right, how to come up with concrete solutions at micro level. We're not talking about what happens in DC, and that's important, right? It's very important. But I think there's a call to action for the private sector, for all of you professionals, to work together at micro level to really have those conversations and say, hey, what would it take to have Ms. Johnson take part in a clinical trial? I was really inspired by the pharmacist, by the way you approach that particular patient. And that's, you know, someone like you, I'd love to talk to you about your work and see whether we can further collaborate in this space. But what I'm saying here is, don't forget the role that you can play in inspiring us, private sector, in working with you to develop the talent bench. And we need that. We need people who really deeply deeply understand the community, and also do not, I mean, I know I'm preaching to the choir here, I know that, but we need to touch our white colleagues. And you said it eloquently a moment ago. They care deeply. You have a lot of people who just don't have the opportunity to do this kind of work that many of you are doing day in and day out. And so we gotta bring them in. And I can tell you, one of the reasons why we were able to make such inroads in the last 4 years in my company is because we were able to explain the opportunity to white folks. We were able to bring, diverse folks into this work, and we're having huge impact. And one final metric, I love metrics, that I will give you is, in the space of multiple sclerosis, right, years ago, we were told Black people don't have multiple sclerosis. It's a myth, of course. And so when you do clinical trials, you don't enroll Black people. You don't enroll Hispanic people, or you have less than 2 or 3% enrolled in trials. And so I gave a challenge to our team to reverse this reality. And so we did a study. It took 2.5 years to perform. So it takes longer because you have to go into the communities, you have to train folks, and you have to build trust. And we presented the data last October. We were able to enroll 40% of the patients, African American, 40%. Historically, it was 2 to 3%. And so, this is just one example. Again, N is one, but there's so much more that we could be doing, we should be doing. So think about the private sector. We're here to partner. And again, Biogen is not unique. I guarantee you there are a lot of other companies that care about this topic, that want to do well, and that want to do good at the same time. So thank you.
Thank you for that perspective. I really appreciate you sharing it. And when we're working with diverse communities, sometimes you have to start with an N of 1, and that's one of the obstacles with NIH sometimes is they don't like the N of 1, but that's where you got to start. So I appreciate you sharing that perspective.
If I can respond for a second. So, gentlemen, I appreciate what you said. So what I would say as a professor and clinician, oftentimes I don't think we're necessarily looking for the private sector relationship, but what I do think about is like contacting minority serving institutions and say, hey, we're looking for experts in this area, right? And once again, I'm not putting it all on you because it's a great point, and I think we were speaking collectively, but it would be great to have an endowed professorship or an endowed chair or something where it says, we want a person specifically dedicated to doing this work in this type of department. So across pharmacy and our public health department and our physician assistant program and psychology, right? That would be great that you would have someone dedicated to that, because unfortunately, I'm doing research kind of on a very thin budget at times, and I don't have time to think, who do I get to fund this next, because I have to do this now. So I think that's a great opportunity to say potential on your end, because if I'm thinking private sector properly, you have a little bit more time and funding to seek us out, if that's okay to say. Miss Patrice Mercadal is in the back. She's our chief of staff. You can talk to her about that.
Okay, please, your question.
Yeah. So I see 4 of you up there, but I see 5 chairs. That 5th chair, the person missing from that 5th chair. I was running in late. The plane was late yesterday, and I was trying to get up here for the reception. And Mr. Vernon downstairs knew where I wanted to go, showed me how to get there, and even pushed the right elevator, because the other elevator is a little slow, but the first elevator is fast. Do we see Mr. Vernon? And do we talk with Mr. Vernon? And do we engage our people, just like you were saying? And I'm glad big grown men can cry. That's great, and that's strength in that too. And the power of the tongues, life or death. So you were right. Try and say something nice and kind. So my question is, how do we look out for the 5th person, the one absent from the chair that doesn't have the voice, who's not really there? How do we get the government, the private sector, the schools, how do we get all these different stakeholders to pay attention to that 5th chair?
I will say, show up, be consistent, and be present. Again, this work doesn't happen without this individual. It's not just creating a space at the table, but it is putting them in that driver's seat, if you will. It is acknowledging that they have the wisdom, the experience, and the knowledge that we don't have. They know what the issues are. They know what their priorities are for health, for themselves, for their community. They know where the gaps are. And so if we are going to truly change, they need to be in the driver's seat. We need to listen to them. We need to build and wrap services and supports and resources around these individuals and stand them up, and then multiply them throughout others in the community to carry on the work that needs to be done, because they have more investment in their success than we do. And so they're going to be more committed to, again, bridging gaps in mental health and physical health and maternal child health and all of the isms and the schisms that impact all of us. And so when we start recognizing this fifth chair as primary, and we take a step back and we say, no, this is about you. How can we help you? How can we better partner with you? Then that's where the true impact of change happens.
Okay, well, we'll have one last question from my boss, so. I gotta let her have my question.
Good place to end. Yeah, this has been such a wonderful discussion. So grateful that you all have been able to join us here at the HEAA Summit. Mental health is something I care a lot about, and as I briefly mentioned during my introduction, it's something I spent a lot of my time in DC in my second career as a policy person focusing on, and I sort of see it more, I'm a caregiver to a person who has a mental health condition, so I always kind of come at it from a caregiver's perspective, and in my research and my work, I've sort of thought about mental health at different levels. So, you have a psychiatrist, psychologist, at one level, but then you also have the barbershop at another level, right? And they're not mutually exclusive, and they should all be working, not that they should all be working together, but we should have access at different points, right? Different access points. And so as we were sort of talking a little bit about those community health workers and not community health workers specifically, but folks in the community that can be those touch points. From a policy perspective, though, I always struggle with how do we train, do we train folks at barbershops? Like, do we train folks at the supermarket? Like, how do we get that mental health literacy out there so we can, no matter where someone is going, whether it's the pharmacy or the supermarket or the barbershop or the psychiatric or the psychologist's office, like, how are we making sure that we're getting folks the help that they need? And what, from a federal point of view, like, are there certain policies that we could be doing to help people be trained or have the resources to provide that care?
So I think what you're talking about is really a no wrong door approach. Someone should be able to access, those services at every level, right? I think funding can be released to train folks in community health work and peer support work, but also the education factor. You have, your barbershops, your nail techs, your grocers. They know this stuff, and they're hungry for the knowledge. I think a lot of times they're shut out because some of the education programs are tailored toward professionals, towards folks like us who can pick up a journal and read these things on their own. So some of the education isn't necessarily tailored to your person who may not be trained in mental health or any other, process. And so I think making that more accessible, making it more readable, and inviting them to, to forums like this for them to become informed. Again, having that no wrong door approach, really helping to stand them up because they're doing the work that we haven't been able to do. And so I think in as much as we can, certainly wrapping those resources around them to continue.
In New Orleans, we talk about folks as culture bearers. And so what I think about is we're not necessarily trying to train individuals to be providers of a service per se. We need people who are anchors in the communities to be able to be the conduit to which people get to those things, right? So that's why I said, like, I talk at Juneteenth programs, I've gone to mosques, I've gone to synagogues, I try to be everywhere. And my normal conversation is just around really consumer, and we talk about this, the consumers of mental health, right? People understanding who does what does a psychiatrist actually do? What does a psychologist do? How do you access your health insurance plan to get these services, right? So I think there can be a very interesting way to have that conversation. One of the things we're talking about a little bit as well, we know that historically at HBCUs, almost 65% of mental health counseling programs do not have a psychologist heading them, right? So that's a space to make sure that on college campuses, counseling centers are actually funded and supported to actually provide quality mental health care. And that's, different ways it can be done. And that's why when I was looking through the bill over Mardi Gras, I didn't read it all, but I read some of it. I was looking at stuff and I was like, well, there are great opportunities to put those access points, those touch points, but oftentimes we miss the cultural barriers, right? And those are the people that we can sit down and say, hey, here are a list of psychologists that if you have someone talking about anxiety, depression, if someone doesn't know what a psychiatrist is, call Dr. Turner, talk to him. As a matter of fact, I often tell clients, I'll do a 15 or 30-minute consult and I'll charge you. I don't care if you're not my client. I need you to get help. I need you to take care of your family. I need you to take care of your child. I need you to be a healthy, productive person in society. And so oftentimes I think the funding does tend to want to go to people with titles and degrees and letters, when what we need to do is have those persons help the people in the community understand the conduit by which these things work, and then get them to the right places. And that would be my thought.
Thank you.
Oh. I just wanted to know, are you familiar with what Shirley McCray did in New York when she trained, did, I guess, layman's training for all that's for the Black boys and kind of with your concept what you just talked about?
I don't know that. I don't know when it happened, but I would love to read about it. But I have been involved with some things here in New Orleans that have been done with the barbers and salons and different things. So I'm pretty sure the model is just being replicated, but I would love to see it, and I would. Okay. Okay. All right. Shirley McCray? Okay.
That sounds great. I'd love to learn more about that. I'm mindful of time, so I'm not going to summarize everything we've said. I'm just going to say that part of our conversation, I heard a lot of references to that cultural taxation piece and really what it means. There's not enough of us out there doing this work, and on those days when you're feeling, you've all had that person that said, I want to work with you, and you're tired, it's 5 o'clock on Friday and you want to go home and you're exhausted, but you have special skills because you work in this space. So on those days when you're feeling run down and on those days when you're feeling culturally taxed, I hope you remember the energy and the spirit and the passion here. There's a lot of energy and spirit and passion, and I'm feeling motivated. I'm hoping that you're feeling motivated. And just remember, you're not alone in this work. You might feel like it sometimes, but you're not. And together we can. I really think together we can. We've got extraordinary leaders such as our Congresswoman Robin Kelly at the forefront of this work, and other members on Capitol Hill as well, Representative Lee, and other people on the Hill right now. So together we can, and thank you so much for your time, and have a great rest of the conference.
Good job.